Hello, hello, YouTube. Hello, Facebook. My name is Jill Osborne. I am the president and founder of the Interstitial Cystitis Network. It is, holy crap, we survived 2020. It is, in fact, January 3rd, 2021. Still technically my vacation. Tomorrow is my official, no, Tuesday is my official day back. But anyway, it's time to do a support group meeting. I thought I'd come on and see how everybody was doing, see if anybody needed any help with their symptoms. The holidays tend to bring out the worst. Stress sucks. Hello, Donna. Yeah. Well, my leg is sore. Other than that, I'm okay. Just trying to get myself together. Whenever I come in and try to do these meetings, Google, I swear, every time makes me re-verify myself. So here I'm all ready to go, and then I get the screen of dread. The screen of dread. Let's see. Hello, Facebook. Hello, Jody. How are you today? Let's see here. Just getting things set up. Donna, how was your holiday? I hope it was good. All right. Come on, computer. Hello, Marcella. How are you today? Ooh, I've got an exciting reveal. I've got an exciting reveal. Yes, I do. Yes, I do. Hello, Kim. Very nice to see you. Oh, hello, Sue. Hi, hun. How is life? How is life? Good. I'm glad your holiday was good. Ours was, um, you COVID is surging here in California. So, yeah, we're not doing much of anything. Hello, Sue. Nice to see you too. Hello, Boria. Hello, Annie. I know, Kim. I figured that one out. Shannon says today is a great day, pain free. Going to start giving my own installation starting tomorrow. Well, if you're pain free today, why are you doing an installation? Why are you doing an installation? Why risk upsetting the apple cart? Hello, Ginny. Happy 2021 to you. Hello, Verna. My ultrasound indicated that I had a narrowing of the renal cortex consistent with kidney disease. Is this due to IC? Absolutely not. No. There's no connection between IC and kidney disease. At least none that they've ever been able to establish in the last 5 years. Hello, Ruth. Yeah. So for those of you who know, we figured out the reason why I wasn't here is because I ruptured two discs in my back early in December. Actually, they think it was just cumulative from the fires and everything. So we're going slow. So my right leg went numb, and my knee went numb, and my thigh and my shin, and it's still a tiny bit numb now. And it really hurts the worst at night. So I had to get up at 4 in the morning and take my quarter of a Norco. Hey, they gave me a Norco for it. So Marcella is getting a urodynamics test next week. You're scared. You don't need to be scared about a urodynamics test. Listen, all a urodynamics test is going to do is determine if the nerves in your bladder are functioning normally. And so basically what's going to happen is you're going to go there and you're going to get up on the table and I just deep breathe. Just guys, the secret to a lot of this is nice centered deep breathing. They will very gently numb your urethra and they will then fill your bladder with fluid. And then they're going to say, okay, tell us when you first feel the need to pee. Tell us when you first feel that first urgency. And then you go, okay, I feel it. And then they're going to say, okay, tell us when you first start to feel discomfort. And then you're going to say, okay, I feel it. And then they're going to maybe push it just a tiny bit more just to see how far they can go. And what it's doing is it's testing your waking bladder capacity along with the ability of your nerves. They're the functionality of your nerves. But honey, ultimately in the end, you are in control. You pay them. They don't pay you. If you get to a point where number one, they're not explaining what they're doing, you need to be vocal and say, I need you to tell me what you are doing right now. And I believe in negotiating a safe word. And it's like, okay, doc, listen, if you want to do this, I get it, but there's going to be a line you cannot cross. And when you hit that line, you need to respect me and stop. You need to respect me and stop. And so I think it's very important that you have a safe word, like uh, pizza, spaghetti, I don't know, whatever. Faith, believe, comfort. And I would just really walk in there and say, "Listen, I'm uncomfortable that you're going to do this. It is not necessary for a diagnosis of IC anymore. It has not been used as a diagnosis of IC for quite some time, although there are some researchers who believe that it will help them try to understand what's wrong with your bladder." Now, listen, I don't like guessing. I like facts. And if you've been in pain for some time, if you've been struggling for some time, then don't force your doctor to guess what's wrong with you. At some point in time, you've got to let them look in your bladder. You've got to let them look. There's a pretty famous story that I share. I think it's absolutely is a fascinating story because I had a patient call me who was terrified of having any testing done at all. So she wouldn't let a doctor look in her bladder for, I don't know, 4 or 5 years. And then finally, it just got so bad. It's like, okay, you can look. Well, you know what they found when they just did a simple cystoscope, which I call a looky-loo. It's like a 5-minute procedure at the most, more like a 1-minute procedure. When they actually inserted a cystoscope and looked in her bladder, what did they find? A giant stone. We call it a bladder stone. It was either a kidney stone that was too big to pass or it was a bladder stone. And stones are very sharp. They're crystals. They're usually calcium oxalate crystals, and they have very, very sharp edges. And so here, this poor woman had this growing stone getting bigger and bigger and bigger in her bladder. And wherever it was floating in her bladder, it cut her. And as soon as they broke it up and removed it, guess what? Symptom free, healed, cured, cured. Okay. She suffered needlessly for years because she let her fear stop her from having somebody look in the bladder. And it's very important, after 6 months, I think after 6 months, that if you're not getting better, if you're not responding to therapy, if you've got blood in your urine, you've got to let them look. Right? I mean, guessing is just not good enough. And my personal philosophy is if it hurts and I'm in pain, I want somebody to look at it quickly. Hello, Carolyn. Jody says, I've been sick, throwing up, and I'm trying to get back on my feet, fighting dehydration. I'm using Pedialyte. Any other bladder-friendly suggestions? And what about vitamin C? Hun, Pedialyte should be fine. And in the new book, which is not out yet, you can Google how to make your own electrolyte solution when you're sick. There might be a way for you to make something at home that might be a little bit more bladder friendly. You can also, of course, just try some clear Gatorade. The clear Gatorade, I think the flavor is, no, the Gatorade that I can drink, no problem, is, what is it? Like passion fruit? Passion fruit. And in terms of vitamin C, yes, ascorbic acid is going to be very irritating for the bladder. Now, you guys, over on our website, icnetwork.org, we have an area on what to do if you've got flus or colds. And of course, the way we did that is I do surveys every couple of years of patients, and I ask them what works for you. And honey is the single most important thing. So products that contain honey, throat lozenges that contain honey are absolutely the way to go. But the other thing people recommended, and I actually brought them into the store this year, to our store, are these traditional medicinals throat coat and traditional medicinals breathe easy. And every year or every other year when I do this cold and flu survey, this always comes up. So many patients use these pretty successfully. And so I would look for these and again, we're all different. I can't tell you if it's going to be perfect for you or not, but I can just tell you that many, many other patients have used these extremely successfully and they've done well. So traditional medicinals, organic throat coat, and traditional medicinals breathe easy. And I am drinking right now traditional medicinals, organic peppermint tea. Mm. Yeah, baby. Ooh, that's good. All righty. So, honey, I hope that you feel better soon. Um, Ascorbic acid, vitamin C is going to be really rough. And that's one of the things, guys, we just released um, our COVID survey. We're the only group that's been studying IC and COVID. And I will tell you that 75% of IC patients who are getting COVID are having pretty significant flares with it. They're struggling with much more intense pain, and it's bringing patients who are in remission out of remission. One of the challenges with COVID is one of the protocols is 1,000 milligrams of ascorbic acid a day, which for you and I, that's going to hurt like hell. If you have to do that, you need to get an ester C. And I don't know, let's see if I've got one here. Yeah, here it is. So look for this. This is a low acid vitamin C. So instead of being made of ascorbic acid, it's called calcium ascorbate. Calcium ascorbate. Okay. So let me do. Ooh, okay. So, it's been a crazy year. And one of the highlights of the year for me was that I got to attend this International Pelvic Pain Society meeting in October virtually. I mean, like one of the really good things now about COVID is that at least with respect to classes and training, so many of us have an opportunity to do things we couldn't have done before. And this class blew my mind because it helped us understand why there's a subset of IC patients, myself included, who end up with IC, IBS, vulvodynia, irritable, let's say fibromyalgia, TMJ. My TMJ has been not happy. Um, and so I dedicated our fall magazine, our fall winter magazine. I did a big double issue because obviously with the fires and then with COVID, we couldn't get our fall magazine out in time. So this is our fall winter magazine. And the lead story is on chronic overlapping pain conditions, and it's everything I learned. So, so y'all know now. Now, listen, we got a lot of people watching here. Not every IC patient is the same. IC is essentially a grab bag diagnosis. So for some people, IC begins in childhood. For others, IC begins as they get much older. Are they the same? Absolutely not. For some patients, IC begins after chemotherapy. For others, IC symptoms begin after falling on your tailbone. Are they the same? Absolutely not. And so, um, and I could kind of go over the history of that. I mean, really, it started in 2008. In 2008 is when we had our first research study that showed that muscles played a role. But anyway, and so now the top tier doctors in the world are doing something called subtyping. Because we don't think of IC as an incurable bladder disease anymore. We don't. And we haven't for years, for more than a decade. We think of IC as a chronic pelvic pain syndrome. Why? Because structures outside of the bladder are often involved. So hold on a sec. Let me just get my slides here. And I want to go over this because then we're going to talk about this article that I did. All right. So in Europe, there are 12 variations of IC. In Europe, if you have symptoms of frequency, urgency, pressure, pain, they do a lot of testing that they don't do here in the United States. And they've got 12 fundamental variants of IC. In Canada, they use a system called Input, which asks patients about their urinary symptoms, what's happening on their bladder wall, what's happening on their pelvic floor, do they have any other neurologically related pain disorders, etc. In the United States, we don't have a nationally agreed upon system. However, I use a system that was created by Dr. Christopher Payne, who ran the IC research program at Stanford University for 20 years. He's also chaired National Institutes of Health IC meetings. So this guy knows his stuff. So several years ago, about 5 years ago, he released what he believed was his phenotyping or subtyping system. And that is, in fact, what I use. So he believes that there are 5 core variants of IC. And but he also says in his article that there are subtypes, there are subtypes. So in some of these core variants, there are variants within that as well. So let's just go over his symptom really quickly. So here is his name for anybody who wants to know, Chris Payne. He's now at Vista Urology in San Jose, California. He's in practice with his wife, Jeanette Potts, and they are the leading pelvic pain center on the West Coast. All right. So in his system, subtype 1 is Hunner's lesions. So a Hunner's lesion, and in fact, we just have a brand new article that came out where they actually give an atlas. They have many, many different pictures of Hunner's lesions for doctors to refer to, because for some people, Hunner's lesions are round. For others, Hunner's lesions look like cracks. But here are some pictures of Hunner's lesions. And generally, what you see is a round center, extremely inflamed with red arms radiating from it. When you biopsy a lesion, it's completely different than everybody else. Inside this lesion is massive inflammation. I mean, a body war is happening. Your body is fighting something intensely in the middle of that lesion. Everybody else does not have the inflammation. It's really just the Hunner's lesion patients. So when they looked at my bladder 3.5 years ago, I got a baby bladder. Man, my bladder looks perfect. And yet there's no doubt that I have quote unquote IC. So if you've had a cystoscope and your bladder is normal, don't worry. We're going to explain that. But for the patients who have lesions, this is considered the most challenging form of IC. Man, these lesions are tough to treat. They only respond to laser therapy, cauterizations. You gotta heat it up and kind of kill that tissue, or injecting it with a steroid to fight the inflammation. So what the hell is a lesion? A lesion appears to be a viral infection. What we have is research from Europe and now research from the United States, again, our National Institutes of Health, which has found a couple of viruses in the urine of patients with Hunner's lesions. It's the Epstein-Barr virus or the polyoma BK virus. Now, we're not talking sexually transmitted disease. Nobody's been unfaithful, guy. Don't even go there. The polyoma viruses are viruses that we all have. They are part of the human biome, or what we call the virome. And what happens is they just normally are very quiet until you get a little bit immune compromised. If you get immune compromised, the virus will turn on and it infects the bladder wall. We have a lot of research studies that have found polyoma BK in patients with what we call hemorrhagic cystitis, bleeding cystitis, because lesions bleed profusely. And that's what these do. They look like bloody waterfalls in the bladder. Okay, so if you've got Hunner's lesions and you're doing Elmeron and bladder installations, those are not going to treat it correctly. Lesions have to be treated when they are found. And I think one of the things that's really sad for me is that patient, in all likelihood, the patients who call my office crying in pain, and they've been in pain for a long, long, long time, they have lesions that were never treated, and they know it. They said, yeah, you have a lesion. But when the doctor did the hydrodissection, he didn't treat it. It's like, what the hell? You are supposed to treat lesions when they are found. And so if you are ever going to have a hydrodistension, it's very, very important that you have a discussion with your doctor about what he intends to do or she intends to do if they find lesions. Because y'all don't want to leave them untreated, because you're just going to have the test again, or the hydrodistension again, to get them treated correctly. And so if the doctor says nothing, I honestly would say, then I'm really not interested in having you do this. You can do a cystoscopy, look at my bladder, but I want somebody who has the equipment and the skills to actually treat a lesion correctly if you find it. Okay? Hunner's lesion. Subtype 1. All right. Subtype 2 is bladder wall driven. Okay, because we clearly know that the bladder, like any other part of the body, can be injured. There's no doubt about that. So this is the chemotherapy patient. A lot of patients going through chemotherapy notice that their bladder symptoms get really bad. Why? Because chemo, it hurts. It hurts the tissue. There's certain types of chemo that are extremely caustic. But this is also, I was working with a patient last week or the week before who was a massive diet soda drinker. And unfortunately, NutraSweet is metabolized into formic acid. And if you went through a stage in the 80s and the 90s where you only drank diet soda, yeah, man, you got a chemical injury of your bladder. But we would expect that to heal. Normally that would heal unless of course you're still drinking something irritating or eating something irritating. So we're going to look at chemical irritation. We're going to look at the quality and health of your skin. Because I hate to say it, but as we get older, our bladder starts to change. Your bladder relies on estrogen to produce that nice thick coating of mucus that protects it. You know, your bladder's like your mouth. It's a hollow organ covered with a really thick coating of mucus. Unfortunately, that mucus is estrogen dependent. So when you're young and you have lots of estrogen, you have lots of mucus and you can get away with stuff. But guess what? When you hit perimenopause or you have surgical menopause, you start losing estrogen. And as you start losing estrogen, what happens is that thick coating of mucus in your bladder gets thinner and thinner and thinner and thinner. This is not a disease process. This is just aging. It means that your bladder's ability to defend itself from something irritating in urine is now compromised. And that happens with aging. So if you've got burning on your vulva, if you've got a dry vagina, if sex is painful in that way, and even dry mouth, because that's what happens is the mucous membrane organs, including your mouth, are affected. Then again, we've got to make sure we're doing the right therapy. And the best therapy for that patient is to give them at first at least a little bit of estrogen so that their body can start producing its own natural mucus. And then, okay, that makes sense because then, you know, and understand you're even with topical estrogen, you're never going to get to have you're never going to have an 18-year-old bladder again. It is older. It is more vulnerable. And that's where doing a therapy that has a bladder coating effect makes sense. And that's where Elmeron was successful. Of course, we now know that Elmeron is linked to eye disease and it's really severe eye disease, including blindness. So Elmeron's pretty done. We're really not doing Elmeron very much. But the chondroitin-based supplements and or if you're in Europe, you can do Hyaluril, which is a chondroitin hyaluronate bladder installation. Unfortunately, we can't get that in the United States. But the chondroitin-based supplements are going to be the Bladder Builder, Bladder Rest, Cysto Protect, Cysto Mend, Cysto Renew. We've got, I'll just show them to you if you haven't seen them. Let's see, did I miss one? Let me grab this one. All right. So if you've never seen these supplements before, and understand that the American Urology Association in their IC guidelines, they want you to try the supplements before you to try regular traditional medications because the traditional medications are associated with a lot more side effects. So generally it's going to be Cysto Protect, which is an older formula, Cysto Renew, or the newest one is Cysto Mend. This is like Cysto Protect, but it has a little pumpkin seed extract in it. Bladder Rest. If you're super sensitive and you're afraid to do stuff, Bladder Rest is the cleanest formula out there. And then the top formula right now by far is Bladder Builder because it also has a pain fighting effect in it. So you can learn about those over on our website if you want to learn more about those. So, okay. So again, we're talking IC subtype 2 bladder wall driven. Variant number 1 is going to be chemical irritation. Variant number 2 is going to be estrogen atrophy, also known as the genitourinary syndrome of menopause. Variant 3 is going to be chronic infection. Some exciting stuff happening here too. So this is where we're going to look. We want to make sure you may be using some next generation DNA urine testing that you don't have a chronic, difficult to isolate infection. So it could be mycoplasma, it could be ureaplasma. But far more importantly, it was our own National Institutes of Health who discovered that many women who were flaring and men who were flaring had, guess what? An overgrowth of yeast or candida in their urine. You can get a yeast infection in your urinary tract. And the latest study, one of the latest study that was released early last year, about a year ago, they identified 13 different fungal species in the urine of patients with IC. And the more fungal species you had, the worse the pain. Now, why would that be? Why would we be more prone to fungal infection? Because if there was ever a group of patients overtreated with antibiotics, it's the lower urinary tract IC patient. How many of us have been taking antibiotics for years and years and years? Many of you self-medicating at home whenever you have a flare, right? Please don't do that. Do not do that. Because what that does, that's like taking a flamethrower to a tropical forest. Kills everything. And then so it kills the bacteria that would normally control the fungus. And so that's why many patients get fungal infections after candida infections after taking antibiotics. And it's really sad. We're learning a lot about the biome right now. And we're learning, I mean, the arrogance of humanity and thinking that we know how the brain works and we know what the biome does is just nothing short of astonishing. There's so much we don't know about what makes our human body function. I mean, think about it. The minute you're injured, your body tries to fix it. Isn't that amazing? And so there's just so much that we don't know about how the bladder works and how the urinary tract works and all of these sort of things. So anyway, chronic fungal infections are real. And we now have next generation urine testing. You can go to a website called bladderhealth.org, and order it there. It's $199. They send you the kit. There's a piece of paper in it. All you need to do is just have any doctor sign it. It could be your primary care, your urologist, whatever. And the urine that you send is like tiny. You send this tiny, tiny amount of urine. It's interesting. And what they do is they look for DNA in that urine. And so that's going to tell you everything in your urine: good bacteria, bad bacteria, and fungus. So that now is indeed your urinalysis today. There was at the American Urology Association meeting last June, there was a keynote speech in which they said the future of urine testing is next generation testing. It identifies far more. Now, hold on a sec. Melanie here says, I have a question. I always notice after I have sex, I'm itchy inside and have urgency. Is that yeast? Hun, it's probably dryness. Dry skin on dry skin sucks, and I can't tell how old you are. I don't think I would really associate that with yeast. And the funny thing about yeast too is that a lot of doctors say, "Do you have a discharge?" And yet, some of these super drug-resistant Candida glabrata infections don't do discharges. I had a Candida glabrata infection for 2 years, super, super drug-resistant. It took forever to kill that sucker. And I will tell you, the pain of yeast in the bladder is far worse than what you would associate with bladder pain. I mean, I was just a wreck. It was so, so bad. Here, what did I do with my thingy? Oh, here it is. It's hot in my office here. Normally I'm cold, but now I'm hot. Okay, so hold on a sec. I gotta just get my hair off my neck. Okay, let's now go to IC. Hold on a sec. Sorry. Okay. Whew. This is a lot of hair to take care of. Ugh. Okay. 1, 2. Hold on, I need a third. Okay. Woo! It's so funny, when you do these, this is work. I'm working talking to you guys right now. Andrea, thank you so much for the 50 stars. Guys, if you find these meetings helpful, you can give us stars on Facebook or, and please, of course, like our page. If you're on YouTube, like our page. And you can go on over to the IC Network and subscribe to our magazine or make a donation, your choice. All right, let's go to the third subtype. So we passed bladder wall driven. Oh, and the key symptom for bladder wall driven is pain as your bladder fills with urine that is relieved by urination. So if as your bladder gets fuller and fuller and fuller, you feel worse and worse and worse. And as soon as you pee and empty your bladder, you feel better. That tells us that your bladder wall is involved. But this is where it gets a little murky. So let's go to subtype 3 for a moment. Subtype 3 is actually the biggest subtype. These are patients whose symptoms began after a trauma, usually a muscle trauma. So if your symptoms began after having a baby, if your symptoms began after you fell, if you were an athlete and like an ice skater or a gymnast or a hockey player or a football player, right? That's when we're going to start looking at your muscles. I call it the chicken versus the egg dilemma. Which comes first, the chicken or the egg? And for us, it's which comes first, the bladder or the pelvic floor? They're both involved. They cannot not both be involved because they're too interconnected, but one is generally driving the other. Why do I have a white spot on my nose? You see that? What is that? Did it go away? Okay, that's just weird. Hold on. Okay, now I've made my nose red because I just touched it. Great. All right. So we know that if you have pain, your muscles will get tight to protect you. That's called the guarding reflex. So if you're going through chemotherapy and your bladder is screaming because of the irritation of the chemo, absolutely, your muscles are going to get tight to protect you. Muscle pain is different than bladder pain. Bladder pain is very sharp and shrill. It feels like razor blades. It feels like ground glass. For me, it felt like really sharp fingernails were being drawn down my bladder wall. Okay. Pelvic floor pain is duller. It's achier. It has a burning quality to it. You might feel like something's falling out of you or something's being pushed up inside of you, right? But the biggest symptom of tight pelvic floor muscles is, in fact, difficulty starting your urine stream. If you can't pee right away, if you're sitting there or standing there 5, 10, 15, 20, 30 seconds before you can release urine, your muscles are freaking tight. That should happen instantaneously. I mean, a muscle relaxes, a sphincter opens, you pee. Normally that's within a second. Man, if you're waiting 5, 10, 15, 20, 30 seconds, you have tight muscles. And this is where it gets really, really interesting because so we know that the bladder can change muscles. That is called a viscerosomatic reflex. But can muscles change the bladder? Yes, they can. That if you have chronically tight muscles, what happens is you create ischemia, oxygen deprivation. Your muscles are so tight, your bladder is not getting the oxygenation it needs to be healthy. It's not getting the nutrition it needs to be healthy. And the other devastating side effect of tight muscles is that it's damaging nerves because nerves need blood supply to function normally. And if they don't have good blood supply, guess what? Your nerves get messed up. Your nerves become maladaptive. I thought, no, wait, is that quite the right word? No, that's not the right word. What is the right word for that one? Your nerves are basically injured. They cannot function correctly. And a dysfunctional nerve releases something called substance P, which is damaging to tissue. And so tight muscles are devastating to the bladder, and they're also often the cause of vulvodynia. Now I had vulvodynia in high school and in my 20s. And the doctor kept saying, "Oh my god, you have the most sensitive skin I've ever seen." No, I had freaking tight muscles back then, and they never caught it. How do I know I had tight muscles back then? Because for me, my symptoms started in junior high because I had a narrow urethra. It was like trying to pee through a needle. What they used to do back then was a urethral dilation with a metal rod. I had about 100 urethral dilations. Nobody ever asked, why is it tight? Why is it tight? And ironically, at exactly the same time, I had fallen and broken the tip of my tailbone off. And it's the tailbone injuries that we see are often the most devastating, that cause the most destruction and damage to the pelvic floor. So, pelvic floor dysfunction is, in fact, the biggest subtype. Far more of you have muscle issues than bladder wall issues. Thank you, Diane. Thank you, Marcella, for the stars. I really, really appreciate that. And so now, if you were to go to any medium level doctor, as well as a national specialist, then one of the very first things they're going to do is check your muscles. What's your muscle tone like? Because if they're tight, we got to do something about it. And that's where some of you make a big mistake because it's like, but I have bladder symptoms. Don't talk to me about my freaking muscles. I don't care about my muscles. I have to pay all night long. That's muscle. Yeah, it is muscle. Um, they send you to the United Kingdom. Oh, wait, no, I'm just reading Jean from the United Kingdom. Jean, I will come back to that. They send you to the physical therapist who will then do a pelvic floor assessment. And their job is to study your pelvis. They're going to look at how you're walking. They're going to measure your legs because if you got one leg longer than the other, yeah, your pelvic floor is going to be tweaked. If you're not walking correctly, your pelvic floor is going to be tweaked. And their job is to touch muscles. And if they can touch a muscle and trigger your pain, bam, that's your hallelujah moment. It's like, oh my God, what are you touching? What are you touching right now? That's it. That's it. That's it. But then as you leave, you go, damn, that hurts. Oh my God. Oh my God. This is terrible. And you don't go back. And that's a terrible mistake. If they can touch it and trigger your pain, you found it. You found it. This is exciting. Now you got to go back and work on that spot. You have to work on that muscle group. For me, it's my left piriformis and now my right piriformis that are the problems. Let me just go back here for a moment because on Facebook here, Jean is talking about the treating embedded infections with high dose antibiotics. Professor Malone Lee says high dose antibiotics don't cause resistance. What are your views on this? So, Jean, this is really, really, really controversial. Several years ago, the Center for Disease Control released their list of the top 10 antibiotic resistant or treatment resistant infections. And millions of patients around the world are struggling with devastating infections that are very, very difficult to treat. Antibiotic resistance often comes from food. So, we have these dreaded superbugs, the bacterial infections that don't respond to any therapy. There was a very famous one in China years ago before COVID, where all these people around this pork farm, this big pork factory, developed this super drug resistant bladder infection. And it was an E. coli bladder infection, and they traced it to the pork farm. And it was scary because it was even vancomycin resistant. That then emerged in Europe. And again, they sourced it out to meat. Because these big industrial farms use a massive amount of antibiotics because they're keeping live animals in close quarters, and that facilitates deadly infections, as we know what happened with COVID. And damn it, China had better shut down all of those live animal markets, which is where COVID started. That's infuriating. That it eventually appeared in the United States in a woman, I think in Philly, who again got this really, really drug-resistant bladder infection. And they eventually found it in several pork farms on the East Coast, these big industrial pork farms. So we know the overuse of antibiotics is devastating, absolutely devastating. It creates fungal infections, it creates C. diff, et cetera, et cetera. Our challenge now is that there are a group of the people who believe, a small but very vocal group of the people who believe that everybody has a chronic embedded infection. And I beg to disagree with that. Number one, we have subtypes. Seriously, if your symptoms began after breaking your tailbone, you do not have a chronic infection. If your symptoms began after having a baby, you do not have a chronic infection. If your symptoms began because you use ketamine, you do not have you simply do not have chronic infection. But some of you might. Where I disagree with Dr. Malone Lee is that he doesn't believe in testing. He eyeballs it. He likes to look under a microscope. So he doesn't think any of the testing is valid. And I think and the great majority of doctors in the world think that that's really, in all honesty, quite reckless, because we have to know what we're treating. And that's where next generation urine testing is so useful, because they basically get a giant strands of DNA that they then compare to big databases. And they can tell you exactly what drug resistancies you have. So they can tell you exactly how to treat it. Now, I want to say something else, though, about this. So, there is a woman now retired. Her name is Ruth Chris. She was a nurse practitioner here in the United States, certified nurse practitioner, who worked originally with Dr. Fugazzotto on the whole antibiotic theory. And I hadn't really talked to her forever until this fall. And she is now doing something absolutely stunning. And that is, she is trying to understand why some of you do have chronic UTI. And her research, she's going into DNA testing and genetic mutations, et cetera, et cetera. I can't wait to feature her and do some of her research here. And again, I'm not talking about everybody. I'm just talking about a small subset of you. But what we're seeing is B12 processing disorders in a small but significant group of patients, also known as porphyria. Now, interestingly, Barbara Flanagan, the founder of the original ICA here in California 30 years ago, was focusing on B12 processing back then. And she had porphyria researchers on her side, and they made a big presentation to the National Institutes of Health asking them to explore this further. They got shot down. She's been working on it for 30 years. Turns out Ruth Chris is working in that area too, only her research is much, much bigger. A week ago, I got a phone call from a brand new porphyria foundation, and they're finding it too. And so again, this is where subtyping is so good, because for some of you, there might be a B12 processing disorder, and we will have more on that in the future. Okay. Whoo, not everybody is the same. This is why Facebook and online support groups are rough here, because it paints broad strokes, and we can't do that with IC. You got to subtype. We got to figure out what the hell you got. You know, it's so sad. You go back and you look at people who did Elmeron for 20 years and who are now blind. They never had a bladder problem in the first place. It was all their muscles, you know? So we got to be really careful here. All right, let's go to the fourth subtype. Subtype number 4 is pudendal neuralgia. So this is a nerve injury. So these are patients who have pain when they sit down, but when they stand up, it gets better. Or they have sciatica, pain shooting down their legs. Like I ended up in the ER a couple of weeks ago with massive sciatica on my right side from my compressed discs in my back. Their pain is electrical. You feel like you're being shocked sometimes, but it's extremely positional, that when you don't move, you don't really feel it. As you start moving, you start to feel a little bit more. And so for these patients, this is essentially a nerve injury. The biggest symptom of this is persistent genital arousal disorder, where you feel like you're for women, you feel like you're kind of aroused, but it's really painful and icky and awful. I call it one of the dirty secrets of IC because we often don't talk about that. We often don't talk about symptoms like that. And that's a really important symptom because if you've got that, then we know you probably have tight muscles and we that are compressing a nerve, which is what I have right now on my right side, right? And so therapy for this is really going to be trying to figure out where the nerve is compressed and then working on why it's compressed, which again is going to be tight muscles, bulging discs, whatever, whatever. Um, the last subtype is now this subtype that has changed. And I wish I had a big marker. I see subtype 5 is central sensitization, where I'm going to be changing this to chronic overlapping pain conditions. So if you have super sensitive skin like I do, okay, where you can't wear wool, man, it's cotton all the way. If you have a wicked sense of smell, you can smell things that other people cannot smell, and smells drive you absolutely bunky. If you have a chemical sensitivity, if you can't take normal doses of medication, you have to take pediatric doses. That tells us that you have more sensitive nerves in your body. Now, and it's not just your bladder, it's through your whole body. I mean, so yeah, this goes back 3 generations in my family. I grew up never being able to use bubble bath because the first time they tried bubble bath, I broke out in a rash and was super irritated. Right. And so, hello, redhead, Norway makes total sense. But this is where this conference that I did. Oh, look at that. My leg touched my thing. Hold on. Okay. Hey man, you know it's not a support group if something doesn't fall or I do my chair. Okay, so let's talk about this subtype a little bit more because this is so exciting. Like we get it now. Why do some of us have IC, IBS, vulvodynia, fibromyalgia? Why? So this is the lead story in our magazine that just came out. I just put it up on our store on New Year's Eve. And you can already get it. If you're already a member, you can already go to your member page and download it. It's going to be mailed next week. All the holidays got in the way. So what was really cool about this conference is that they were trying to explain why this happens. And it's going to sound scary at first, but it's not scary. But you're just going to go, whoa, why is she talking about the brain? Okay. So Connie here on YouTube says, yeah, this is me. I'm way sensitive to smells and chemicals. Yeah, me too. Okay. So about 15 years ago, the IBS, the fibromyalgia, the TMJ, all those foundations got together and they created what we call the Chronic Pain Research Alliance. And the Chronic Pain Research Alliance has been trying to figure this out. Why does this happen? And they were the ones who started doing brain studies. And, you know, it was very hard for me to talk about it to you guys. It's like I didn't really understand the relevance of it. But what they consistently found was that the brains of somebody with many, many pain conditions was functioning differently. And then our own MAP Research Network, the IC Pelvic Pain Research Network that's been going on for about 10 years, they started doing brain studies and they found the same thing. They found the same thing that somebody with chronic overlapping pain conditions, they are functioning in a constant state of fight or flight. Let's see, how do I want to say this? Remember, 5,000 years ago, if you saw a saber-toothed tiger walking towards you, when you walked out of your cave, you stopped and went, oh. What you didn't know is that the purpose of your brain. It's to protect you, right? And the purpose of what we call your sympathetic nervous system is that's what takes over when you're under threat. So you see that saber-tooth tiger, you're like, oh, your heart rate increases, your blood pressure increases, your muscles get tight, your insulin levels change because your body is preparing you to fight for your life, right? And then once the stressor has passed, once the threat has passed, the sympathetic nervous system turns off and the parasympathetic nervous system, which is the one that you should be on all day, comes in and it lowers your blood pressure. It reduces your heart rate. It relaxes your muscles. It normalizes your blood sugar, right? But guess what? People with chronic overlapping pain conditions, the switch isn't turning off. It's called the amygdala in the brain. There's an area of the brain called the amygdala, which controls that entire fight or flight response. Thank you, Marcella, for your 50 stars. I really appreciate that. So, what these studies are consistently finding is that our amygdala is not turning off, that we are stuck in fight or flight. Now, the challenge with that is that let's see, you essentially get into adrenaline overload. You got so much. I mean, first of all, take it from somebody who's been there. The negative thoughts are overwhelming. It's like, oh my God, it's another flare. It'll never go away. Oh my God, if I go to the doctor, he's just going to hurt me. Oh my God, why would I go out? I'm just going to have to leave and embarrass myself. Oh my God, no, I'm not going to go to the movies because I'm going to have to get up and pee. Oh my God, no, stop it. I'm not going to drive anywhere. It's like your brain is in a constant state of no. No, no, no. We call that catastrophizing. Anxiety. The anxiety is really high also. And this is not a mental illness. Nobody's saying this is a mental illness. What they are consistently saying is this is a maladaptive nervous system. That nervous system is stuck, and we have to get it unstuck. So the best part of the conference was a pediatric risk factor conference, a class, because it happened to me. I was like, okay, why? Why did this happen? It's been like the big mystery of my life. Why I'm the person I am today? Why we're in 20s messed up with all of these related conditions. And what they consistently found is in the child, within a year of the onset of their symptoms, they suffered a physical trauma of some type. So I broke my tailbone for sure, 100%. So for many of you, there was an original injury, something completely innocuous, jamming your crotch on the bar of a bicycle if you were a boy or even a girl. But boys particular, you're not going to go home and tell mom, hey man, my balls hurt. You're going to hide that. Okay. But there's also a subset of patients, but it's a much smaller subset of patients, but it's still there, of patients who were abused. They were abused. And the best way I can explain it to you is think about a new puppy that goes into a family where there's an abuser, a dog abuser. And that puppy is waving, man, it's waving its tail. I'm so happy to be here. I'm so happy to be here. And then when nobody else is looking, they get kicked. And then the puppy comes back. I'm so happy to be here. I'm so happy to be here. And then they get kicked again. And slowly the puppy's behavior changes. The puppy stops wagging its tail. The tail is in between. The puppy's not behaving normally at all. The puppy's afraid to come inside the house because every time it came into the house, somebody's kicking it. Somebody was obviously mentally ill. And in the end, you've got an animal that is in complete and total fight or flight. It's afraid to do anything. It's sitting in a corner shaking when anybody comes into the room because it's been beaten so badly. And that's happened for some of you too. We know that. We have research to prove that some of you have been abused. And I'm so, so sorry that happened. That you And you're like that puppy. When you walked into that room with that abuser, you were startled, fight or flight. Like, and your brain was just every day, fight or flight, fight or flight, fight or flight, fight or flight. Adrenaline levels high, adrenaline levels high. Bam. There you go. We have a brain now that is hyper vigilant. One of the things we knew early on is that IC patients, some IC patients had a really high startle response. And I'm one of them. I'm absolutely one of them. Where you're driving and it's like, whoa, what was that? And that again tells us that the central nervous system is really hyper vigilant. It also happens to adults. If you're in an abusive relationship, obviously, or if you're at work, you have a bully at work. I was been thinking about that a lot because I've dealt with quite a few bullies, even in the IC community. We've had a couple of really wicked bullies who've done their best to try to bully me. And um, if you're in a situation where every single time you drive to work, you've got somebody who's a bully, you are in fight or flight every single day. And that's not the way it was meant to be. And not only are you in fight or flight every day, you're in fight or flight every hour of every day while you're working. Until finally, as you leave, you might be able to breathe a little bit more, but that doesn't counteract all the damage done by all the adrenaline and all that other stuff. So, how do we turn off the amygdala? You can turn it off, my friends. You can turn it off. And the research is stunningly good. The research from Harvard Medical School is amazing, absolutely amazing. So, one of the best ways to turn off the amygdala and to turn off the fight or flight, obviously, is going to be relaxation, meditation, stuff like that. But it's about involving your senses. We have to involve the senses. And so, there's a wonderful technique called I Spy, where if you're really stressed out, if you're really anxious, you're walking into a situation you don't want to do, let's try I Spy. So let's do it right now. Okay. So I Spy means we're going to involve every single one of our senses with deep breathing. So let's just do it. Number one, let's take a nice slow deep breath in, out. And I know y'all are asking a lot of questions. I will come back to those. I promise. In, out. All right. Look around your room. What draws your eye? What are you looking at? I got a beautiful glass sculpture right here of a firefly. So I'm looking at that. Okay, now taking a deep breath in and a deep breath out. Okay. What do you smell? Can you smell anything? And for me, I can smell my mint tea. In, out. Okay, what do you taste? Did you just have lunch? Did you just eat a snack, some popcorn? You sucking on a piece of chocolate, which is a no-no. What are you tasting? Anything? For me, I taste a little bit of mint and a little tiny bit of lemon. In, out. Okay. Now touch something. Just touch something. So I'm going to touch my yoga pants. Nice soft cotton. I like it. Are you wearing a sweater, chunky sweater? You wearing your robe, wool, whatever, fiber? Touch it. What does it feel like? Mine is very soft. I love it. Okay, in, out. Now, what do you hear? Now, I know you're listening to me, but do you hear anything else? Like I hear a car idling out the window. Okay, in, out. What that does is that forces the parasympathetic nervous system to take over. Because remember, the brain's job is to process your senses. So that's what we're doing is your brain is like a thunderstorm, lots of different things lighting up at one time. What we're trying to do is we're trying to get your brain to focus on your senses instead of the pain. So now the second part of I Spy is okay, what could you look at that would always put a smile on your face? And for me, it's my beloved cat, Sammy, who I lost a couple years ago. Doesn't matter. All I have to do is visualize her in my eye, and oh my God, I loved her so much. Okay, in, out. What could you taste that would put a smile on your face? Hot cinnamon roll. In, out. What could you smell that would put a smile on your face? Coconut. I love coconut. Okay, in, out. What could you hear that would put a smile on your face? Hmm. For me right now, it is BTS's song Microcosmos, which I play several times today. Okay, in, out. What could you touch that would put a smile on your face? Petting my cat or giving my mom or dad a hug. In, out. Right? Now, let's just check in for a moment. Don't you feel like relaxed? Isn't that cool? So I had to have an MRI, and an MRI for on my back last week, and the narrow tube that you go in, and it's very loud. And my sis tried to do it, and it was just a lot of people try to do. If you're claustrophobic, you're really really messed up, yeah, and you can't do it. They give you the control so you can stop it, but I was like, I walked in there strong, determined. Man, I wanted to know what the hell was wrong with my back and why my knee was numb. And so this is what I did to count 30 minutes in an MRI. The first thing I did was my chakra meditation, which I used to do swimming. You can Google that. That took about 5 minutes. Then I did my affirmations. I can do all things through Christ who strengthens me. Be bold and mighty forces shall come to thy aid. Is doing that, right? That was another couple minutes. Then I did my I Spy. That was about 5 minutes. But damn it, I still had about 15 minutes to go. And so I started counting by 7, 14, 21, 28. I got all the way to 700. And you know what was really interesting? Is that as soon as I started counting and working my brain that way, zero anxiety. I could have counted for another hour and been in that machine. And that's what all of these studies are showing is that we have to keep the brain busy with other things. And that's why they want you to do puzzles and they learn languages and read books and make your brain work. Because the more you make your brain work, the less it can pay attention to other dysfunctions. And again, it engages the parasympathetic. Okay, so anyway, listen, guys, I can go on and on about this. Hello. If you're at all interested in this, come on over to our website and you can buy single copies of this and download them. This is the longest article I've ever written. I give many, many techniques proven by Harvard Medical School to reduce the symptoms of chronic overlapping pain conditions. And the reality is, listen, seriously, you can't kid a kidder here. I've been there. If you're struggling with anxiety every day, we got to work on that. I'm not saying the anxiety is the root problem, but what I am saying is anxiety is only going to intensify your pain. And we got to retrain that brain to calm the entire central nervous system down. So I'm super, 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 super excited. Oh my God. Now, I guess I had never even introduced myself. I'm Jill Osborne, president and founder of the Interstitial Cystitis Network. I'm the longest serving IC support group leader in the United States. Now, I'm pretty confident in saying in the world. I do these meetings every Sunday, as much as I can, as long as I don't have other things going on. That's enough of me talking. I want to get to some of your questions here now. I'm not going to do any more lectures, but I'm going to start the new year off the right way. So here on YouTube here, hold on a sec. So we're simulcasting live on Facebook and YouTube right now. And I want to go back to YouTube here for a moment. So hold on a sec. Denise says, I'm going to a new urogynecologist this week. I'm determined to get to the root cause of my IC. Is it autoimmune, hormonal, embedded infection? What tests help diagnose these different causes? Okay, so number one, when you go to a doctor, don't walk in and say you have IC. Please do not do that. If you walk into a new doctor's office and say you have IC, you have fallen into the pit of IC and the pit of history. Remember that many medical schools didn't provide good education about IC. You need to walk in and be prepared to talk about your symptoms in depth. You say, so it's like, hey, doc, I cannot sleep through the night. I'm getting up to urinate every 10 minutes. Okay, there you go. But what's really weird is when I get up to pee, man, my vulva is hurting like crazy. So I not only have frequency, but it burns, and it burns as it's coming out of me. Okay, that's an immediate clue that you've got estrogen atrophy. That's an important symptom. So is your pain inside of your body? Is your pain outside of your body? Is your pain to the left? Is your pain to the right? Do you not have pain at all? Maybe you've just got frequency urgency. And the devil is in the details here, because oftentimes it's a little weird, and the weird symptom that you don't even think to tell your doctor that is the symptom that will help figure out what's going on. So, do you have pain every time you sit down? Does it get better as you stand up? Do you feel like something's falling out of you? Do you feel like something's being pulled out of you? Do you feel like something's being pushed up inside of you? Do you feel like there's a foreign object in your urethra, in your vagina, in your rectum? Do you have rectal pain? Are you constipated? Constipation is linked with tight muscles, along with other things, obviously. Is sex painful? Do you have a flare after sex? Don't say I see. Please talk about your symptoms. And if your symptoms are always in a specific spot, it's like, Jill, my pain is always just to the left of the base of my penis. That's not IC. That's something at that spot. If you've got pain always in the same spot, we got to get them to study that spot. The other thing, guys, is when they do a diagnostic workup, not only are they going to do your history, you need a physical examination. We need hands on your body here. And normally now at every first appointment, they always do a pelvic floor assessment. We want them to look at the muscles. We want them to touch the muscles. And we also want them to examine your skin to see if you've got signs of estrogen atrophy, the skin health, muscle health, bladder health, etc. Okay, so here, hold on. Lisa says, I believe I've seen all the top doctors and physical therapists, and they are all stumped. So, Lisa, come on over to our website and look at the confusable conditions, because could you have a fibroid tumor pushing on your bladder? Could you have a Tarlov cyst at L4, L5? Is there something else that is confusing the diagnosis? It's possible. And honestly, Lisa, I would absolutely have a next gen urine test. Let's just figure it out. See if there's anything funky in your urine. Could it be a candida infection in your urinary tract that they've all missed? Because typical urine testing does not find fungal infections. The Sin Squad says, "Oops, I thought it would help me to go on a hormone blocker, so now I have less estrogen in my body than ever. I should have gone in the opposite direction." This is where it's everybody's different, you know? I mean, if you've got endometriosis, so this kind of gets back to why I'm so excited to learn a little bit more about Ruth Cruz's research, because what she found with some of the work that she was doing is she could explain why some patients are estrogen dominant and throwing ovarian cysts and throwing endometriosis. I don't remember the exact mechanism of action, but it was fascinating. So if you're estrogen dominant, then yeah, it makes sense to do something that would reduce your estrogen. But it's a delicate balance there. Kath said, "Thank you, Jill, for the insight. I had no idea menopause, the link to IC. Oh, girl, genitourinary syndrome of menopause." Dr. Jennifer Gunter is going to be releasing a new book on menopause this year. I can't wait to read it. She wrote the Vagina Bible last year. She's fabulous. Lisa, also, let's see. Kath says, "Jill, wondering if dairy products are harmful to IC people. I drink a lot of milk and bran cereal." If you're lactose intolerant, certainly. I found for me, even though I don't have, kind of a traditional allergy, whatever, to lactose, I learned in my 20s, I just did better when I didn't do a lot of dairy. Um, I found that when I did a lot of dairy, things got very mucousy and crampy, and I didn't like that very much. A little bit more concerned about the brand cereal, because here's the deal: is if you're in this central sensitization group and you've got, oh God, oh, I did it again. I keep moving my feet around. Hold on. I should be sitting on my yoga ball, then that wouldn't happen. Okay, so if you got irritable bowel syndrome, that means that you've got sensitive nerves in your bowel, right? Okay, why is my shirt doing this? Sorry, got to fix this. And I had IBS in my 20s, when all this happened. And of course, now we know why. We know the chronic overlapping pain, whatever, central sensitization. Foods that are composed of fibers that are composed of, what's the right word here? I'm having a brain moment here. What's the right word? Hydro. Is it hydrophobic? No. Soluble versus insoluble. Woo! Okay, so traditional brand cereal is usually composed of insoluble fibers. Insoluble fibers are going to be things like bran, granola, lettuce. Insoluble fibers are hard on the gut. They have sharp edges. And whereas a soluble fiber is a fiber that dissolves in water. It is smooth and gentle, like acacia fiber. And so generally patients who have irritable bowel, they don't want you to do a insoluble fiber because it just provokes more nerves. They want you to do a soluble fiber like acacia fiber instead. So I am more concerned about the brand cereal you're eating as compared to the lactose and the milk. And I think, do I have it here? Let's see here. Here it is. So we have two soluble fibers that we sell: Heather's acacia fiber, Heather's tummy fiber, or Regular Girl. Regular Girl is, let's see, I think it's acacia fiber, but also with some bifido. No, it's guar fiber. Sorry, guar fiber, but it's still a soluble fiber. So, and then also Natural Approach Nutrition is coming out with their own fiber. I just saw the design for that last weekend. Woo, that's exciting. Lisa, severe muscle atrophy, poor body stability, nerve testing negative. These are the top experts who are stumped, debating contacting Mayo Clinic. I would say no to Mayo Clinic because Mayo Clinic is actually quite dismissive of patients who struggle with IC and pelvic pain. If you can barely walk, I mean, have you been to an orthopedic surgeon? Have they looked at your spine? I was having trouble walking because I had compressed nerves. I've got um, a ruptured disc at 3-4 and 4-5. And believe me, you should see me walking. Some days it's really quite bad. They say it's healing, so I don't have to have surgery, but I can't lift anything for 3 months. So, the severe muscle atrophy is not part of IC. That's not part of a chronic pelvic pain. You got something else going on, hon. Sin Squad said, you guys gotta tell me if I'm wrong about this, but from my research, any food could be harmful since sometimes IC symptoms are caused by histamine mast cell reactions. No, hon, that's not true. That's just not true at all. Remember, number one, not everybody has a bladder wall issue in the first place. More of you have muscle issues than you do bladder issues. Some people do have a mast cell syndrome, and they would determine that by doing a biopsy of the bladder wall. Denise says, where does autoimmune fit in these subtypes? The only autoimmune variant in IC is Hunner's lesions. The rest of us do not usually have an autoimmune subtype. IC does not meet the criteria for a true autoimmune disease. The only autoimmunity that's questioned is patients with Hunner's lesions. And you know that because when COVID came out, the ICA released a statement saying that people were asking, are you more vulnerable to COVID because you have IC? And the answer is no, because it is not autoimmune unless you have potentially Hunner's lesions. Then you could have a little autoimmunity issue. Denise says, I went on the IC diet for a year after my first symptoms. This past year, I was able to eat everything I wanted. I recently began having symptoms again. So, number one, Denise, you could be getting older and you could have a little bit more estrogen atrophy. That would explain one reason why you might have more bladder sensitivity, or it could be your muscles are getting tighter again. Food doesn't bother me so much anymore. Hey, Kara, thank you so much for the 50 stars on Facebook. That is awesome. I really appreciate that. Somebody's talking about marshmallow root. Anyone have ideas for making it palatable as a tea? No. Marshmallow root capsules are usually the way to go. Denise says, Jill, thank you for taking the time to speak with us weekly for so long. It's been tremendously helpful to me, and I'm sure to others as well. Oh, I'm so glad, hon. All right, let's go to Facebook here now. Hold on, I got to open up my screen here. Okay, so you guys on Facebook, I'm 45 minutes behind in answering your questions. I'm sorry about that. And we're going to have to start a Zoom meeting probably in about 10 minutes. But so if I missed it, you can just please re-ask it. Don't take it personally. Nerdin is, let's see, Judy says, I only feel the urge to urinate in my urethra, not my bladder. Okay, so Judy, estrogen atrophy. The urethra is kind of like the canary in the coal mine when it comes to um, crying when your estrogen levels drop to a certain point. And so, what we often see are people who struggle with urinary symptoms or urethral symptoms first. And for me, it happened when I was 51, and it felt like there was a drop of urine stuck in my urethra that would not come down. And the way we fix that is with using a little bit of topical estrogen. Nurdin is saying that fulguration of Hunner's lesions was not as effective as steroid injection. Yeah, steroid injection makes more sense because it's getting in there and reducing inflammation. Vicky, thank you for the 150 stars. That is so wonderful. I really, really appreciate that. Dina said, I did have lesions. They treated me with low dose antibiotic for a month and then went on D-Manos. Didn't get another flare for like 5 years. Dina, did they find that lesion with a hydrodistension? We don't have any evidence that lesions are the result of bacterial infection. What we're finding, again, is a viral infection. Atara says, hello, Atara. Oh, you guys, we have somebody famous in the room. Atara is a fabulous artist. Oh my God, please. Her artwork is nothing short of astonishing. And you can see in the back here, I have some of her. Can you see right here in between these? We will be heard. Believe in your healing. If you Google Atara Shamel and you take a look at her art, her Project Angel series is nothing short of astonishingly beautiful. And this is something I keep on my desk. It is a painting that she gave me. And you can see it says, "My soul has a specific and deeply important mission to fulfill." Atara Shamel, my friends, is somebody who put her pain to work to help others. And her series, I mean, her art has been displayed in art exhibitions, and she tells the story of life with chronic pelvic pain. So Atara says, the brain damaged by drugs. I hope that you know that, Jill. Of course. Well, no, not all drugs are not all drugs. No, 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 no. Some drugs are life-saving. Others, like ketamine, can be incredibly damaging. But you guys check out Atara Shamel's Project Angel. You can get gift cards. She's wonderful. Anne Rush says, what is vulvodynia? Vulvodynia feels like you've got a yeast infection, but when they look at your vulva and they find nothing. They can't explain it. It's a sensitivity of the nerves in the vulva for some of us. For others, it is estrogen atrophy and so forth. Casey's talking about urethral dilations, French catheter, metal rod, killer pain thread. Yeah, girl. Amen. I was there. Sarah says, I'm 31 with pelvic floor dysfunction and Hunner's lesions and retention. Sarah, number one, you're not alone. And generally, we can figure out how and why some of these things are happening. And so if you've got Hunner's lesions, you need to make sure the lesions are treated correctly, perhaps with steroid injections to try to calm them down. If you've got retention because you've got tight pelvic floor muscles. And the odds are it was the pelvic floor muscles that began this whole process for you. Be very interesting to find out if you were a child athlete. You know, were you a gymnast, ice skater? Can you remember any traumas, any falls, anything at all like that? Donna says, I have pain 24/7. It confuses me that my mildly touching my bladder area starts a major pain cycle. What would be the cause of getting so much pain from mildly touching? Donna, that's called allodynia. And they explained that at the International Pelvic Pain Conference that I went to. So basically, let's see if I can do this correctly. Let's see. So how do I want to explain this? Let's say that you suffered an injury, like you broke your tailbone. Okay. The way the body reacts to injury is interesting because and I didn't know this, at the very start of the injury, your body actually intensifies the pain. And I don't quite understand why, but it's part of the, I can't remember the exact word. Um, it's part of the inflammatory process. There's an inflammatory marker that actually intensifies pain to begin with. And then normally the injury would heal correctly and things would calm down. But if it doesn't, what happens then is the proximal nerves in the area also get involved and they also become tender. So if it started in your bladder and then you notice that you've got sensitivity on your vulva, that's a proximal nerve. And remember, all these nerves emerge up at the spinal cord anyway. And so everything in the pelvis ends up at the spinal cord in almost exactly the same nerves. And so if one group of nerves gets sensitized, there's something called neurocrosstalk where the other nerves also get sensitized. And we start getting allodynia. We get pain in the surrounding tissues that were never hurt in the first place. So I went through a period for about a month where you couldn't touch me from the waist down. I mean, just the lightest touch on my stomach caused terrible pain because I had extreme allodynia. And so what we've got to do is we got to calm all the nerves down, find the original source of the pain and start working on that. So my guess would be that you've got a pretty significant case of allodynia going on. You got a lot of super irritated nerves. So we got to figure out why. Are they irritated because they're being chemically irritated? Or are they irritated because you got tight muscles? Could be either one. Kathy Meyer says, COVID really messed up my IC. I recently had an instill. Let's see, I recently had an instill. There's typos in there, so I can't really, or the spell corrector is changing it. All my symptoms are off of whack, and it's been 2 months. So in our magazine, we also go over our COVID and IC survey. We have about 92 patients now who have had COVID, who have participated in our small research study, and our goal here has been to try to figure out why, how COVID affects IC patients. We do know that active virus has been found in the urine of patients in 14 studies. Generally, in adults, they're moderate to severely ill patients, but they have been found in every child with IC. We know that COVID can infect the kidneys. And so our survey found that 74% of IC patients worsened with COVID, IC symptoms worsened with COVID infection. 23% reported that their symptoms stayed the same. And in our study, 10%, basically 9 patients were hospitalized. Bladder pain increased severely in 34% of patients, with 42% reporting a moderate or slight increase. 24% reported no change in their pain. For some patients, their bladder symptoms appeared suddenly, while for others, it intensified a week or two after COVID infection. We see the same breakdown with frequency, where 26% reported that their symptoms became, their frequency symptoms became severe. Some patients reported that they were brought out of remission and are now struggling with IC symptoms again. Others shared that their normal treatments and flare tips, such as rescue instills, were not working as they had before COVID-19. And the other thing that's interesting about COVID-19 infections for IC patients is it caused a lot of abdominal pressure, bloating, and burning during urination. And yet, for a small group of patients, their symptoms went away completely. So there's a lot of patient stories in here, and all our data from what other patients were sharing. So if you've had COVID, you might want to get this magazine so you can share it with your doctor, because this is the only IC COVID study that's been done. You can go over to the IC network, into our survey center. Oh, did I even put it in our survey center? No, it's in our blogs on our website. You can find our COVID blog, and if you've had it, please participate. We need data. I'm going to send this off to our medical board. I think they're going to be fascinated. Irene says, when I drink water, I get a lot of pressure. Drinking a 16 ounce is a challenge. Why does this happen? Well, if you've got a sensitive nerve, if you've got sensitive nerves in your bladder, or your bladder's been irritated, the last thing you want to do is stretch it. An IC patient, by how they drink water, they're not going to drink a glass of water in one sitting, because you don't want all that water to arrive in your bladder at one point in time and go, woo, that's going to hurt. We generally sip a glass of water over a period of an hour instead. That's a much more gentle trickle. Or you can see here, look at this. I mean, I barely had this, and I've been talking now for an hour and a half. Brenda says, what does it mean, Jill, when you have the pain, symptoms, and relief of all the subtypes? Well, listen, if you got Hunter's ulcers, you're going to have tight muscles, because Hunter's ulcers hurt, and that's going to make your muscles tight. And if you've got super tight muscles from Hunter's ulcers, is that going to compress a nerve? Yeah, it could be. And then if you've had pain for a long period of time, then is that going to sensitize other nerves? Yes, it is. So it's possible. That's why we got to work on all of those. If you just do bladder stuff and you ignore your muscles and all the other stuff, it's a problem. Kathy says, "You're in a lot of pain. It's almost impossible to get pain meds and marijuana in Iowa. I've tried everything. Have you tried palmitoyl ethanolamide?" We had a brand new research study that came out last year that showed that PEA was remarkably successful at reducing pain in IC patients. And it's in 2 supplements. It is in Bladder Builder. And then we also have, where is it? Oh. Peora. Peora. This is the formula that was used in the IC. It's as close to the formula as we could get to this formula used in Europe for the IC research study. In the IC research study with PEA, what they found was by month 3, 87% of patients using PEA had a significant reduction in their pain. And by month 6, 25% of those patients were now pain-free, and the rest were doing remarkably well. And in our 1-year bladder builder survey, that's the one thing we found is pain had improved dramatically in the patients who were responding to this. So about 60% of patients who tried bladder builder are still using it. They 25% were pain-free. The rest reported less intense flares, fewer flares, and shorter flares. And then we also have PEA in aloe for those of you who like a soothing effect of aloe. So on PEA, for anybody struggling with pain, we got the research now to back it up, presented at the American Urology Association, that shows that PEA can be remarkably successful at reducing pain in IC. Hello, Karina from Sweden. Hello, I have family in Sweden and Norway. All you need to do is go to our website, icnetwork.org, and just sign up for the $25 subscription. And yeah, you can just download it from your member page. It'd be a PDF file. John says, has PTNS been helpful for IC pain? More for frequency, urgency, but it has been for some people. It broke me out of a wicked flare when I did PTNS. Lynn, thank you so much for your 150 stars. That's so sweet. I really appreciate it. John, PTNS, post-tibial nerve stimulation, is the least invasive form of nerve stimulation. And that's really where they're targeting now for people with IC subtype 4 pudendal neuralgia in terms of calming nerves down. And very, very few side effects. So it's definitely worth a shot. Much safer than doing InterStim. Okay, guys, I need to start up the Zoom portion of our meeting. So hold on a sec. So the way you get into our Zoom meeting, I will put a link in, but you can also go to the IC Network webpage and go to support, the support area, streamed support group meetings, and there's an invite right there. So that's where I'm going right now. Do I want to allow this page to open Zoom? Yes. So the purpose of the Zoom meeting is to give you an opportunity to come in and talk to me and ask your questions. So let us see here. I'm going to let you in. I always let you in one at a time. Now, as soon as I put this invitation in, I'm gonna lose some of your questions. I am sorry to say. So hold on a sec. No, I'm not gonna play music right now. All right, so John asked, "Am I using Urgent PC?" No, I did it with Dr. Marshall Stoller, the guy who invented it. Urgent PC took over afterwards. Karen says, "Where does the American Urology Association stand on that?" I'm not sure what this is. You mean on subtyping or on these? I'm not sure. Okay, so you guys, I'm going to lose a lot of Facebook questions. You're going to have to ask them again because I got to scroll down to the bottom and give you the invite link to Zoom. Okay. Facebook, you have it. YouTube, I missed you last time. I apologize for that. I'm posting it. Hold on. Okay. YouTube, you have the link too. Now, so with Zoom, I'm going to leave Facebook and YouTube open. Yeah, you're all going to hear that. You're going to hear it, but you're only going to see me. You're not going to see them unless you come into the Zoom meeting. Hello, Anne. And so while we're waiting for people to come in, I'm just going to keep going through your questions. Jill says, is Bladder Builder, it's always nice to meet another Jill. Hi, Jill. Is Bladder Builder a substitute for Elmeron? Yes. Yes, it is. With chondroitin in it, we had a research study presented last year, which showed it was at the European Society for the Study of IC that showed that chondroitin was the most effective at restoring the superficial integrity of the bladder wall. So chondroitin. So that's going to be bladder builder, bladder rest, cysto mend, cysto protect, or cysto. Samantha says, trying a new specialist in March, fingers crossed. Okay, so in the meantime, while you're prepping for that, Samantha, you got to start writing down your symptoms, girl. Pay attention to the little weird ones. The little weird ones are the important ones. Jean says, can you buy Pura in the United Kingdom? No. Look for UMPEA, or look for palmitoyl ethanolamide, PEA, in a local store. Brenda Cole says, Pura is amazing. Yeah, baby. It's what I take when I'm having issues. I take Pura. This says, I asked to have my bladder removed after one surgeon tried excising a lesion, not knowing what it was causing, that it was causing scarring, so much pain. He said it just doesn't work that way. Samantha, I think we all did that at one point in time. I mean, I begged my doctor to take my bladder out in the fall of 1993. Dr. Mark Klein, please take it out. The pain was so bad. And basically, he said, no, we have a lot of therapies. I'm not going to take your bladder out until we work through stuff. And thank God, because you know what? My bladder's healthy. There's nothing wrong with my bladder. And it would have been tragic to take my bladder out. My problems were primarily central nervous system problems. Nan says, are there any supplements for tight muscle-driven IC? There's no supplements really that we have right now. We have to try to figure out why your muscles are tight, and maybe the Pura might help reduce pain, but magnesium, B12, you got to talk to your doctor, see if there's anything else that might be doing that. Christine says, what are my thoughts on getting the COVID vaccine? Oh, hell, I'm getting it. Are you kidding? Absolutely. 100%. 100% will I be getting the COVID vaccine. I care for a 98-year-old and a 91-year-old, and I do not want to carry guilt in my heart for bringing COVID to them and killing them. Let me tell you, as soon as I can, I will. Sue, I've been advised to have my bladder removed. They refuse to treat my Hunter's ulcers. What should I do? Sue, you need to go to a top national specialist. I don't know where you live, but that's going to be Robert Evans at Wake Forest University in North Carolina. Ken Peters up at Beaumont Health in Detroit, in the Detroit area. Robert Moldwin in New York. Phil Hanno at Stanford. If they refuse to treat your Hunter's ulcers, they don't know what the hell they're doing, because Hunter's ulcers can be treated. If you'd like to talk sometime, I'd be happy to talk with you. Somebody's asking where your favorite injections of ulcers are. There's really only one injection for ulcers, and that's going to be triamcinolone steroid. All right, let's go to we're going to do the Zoom meeting now. So let me just turn this volume up. And I'm going to go to Anne first, because I think Anne came in first, right?
Yes.
Hello, Anne. How are you today? How is life treating you? And Happy New Year to you.
You too. So I'm going to a urogyno this week. So what test will they be doing? What tests will they be doing to see if I have IC?
Well,
I'm pretty sure I have it. I have your frequency and.
Okay, so there's no definitive test that will prove that you have IC. It is a diagnosis of exclusion. So generally what they're going to do, now remember, what do I say? Do not walk into that appointment and say you've got IC.
Right. Thank you. I was going to
Your
do that.
goal is
So,
to get them to study your body based upon your symptoms. So your
okay.
goal is to say, okay, I'm here to try to figure out why I can't sleep through the night, or I'm here to figure out why I have pain when I sit down. So what, number one, how old are you?
I'm 64.
Okay. Most importantly, they've got to look at your skin. The quality and health of your skin matters. You absolutely are in estrogen atrophy now.
Yes, I am.
And if you've got dry vulva and dry vagina, you have dry urethra and dry bladder. And that is probably what, especially, when did your symptoms start for you?
Oh, I've had it on. I went to another urogyno and I was diagnosed by my symptoms, and I did pelvic floor and I use a wand, but now she's no longer in existence. So I had flares. So I'm going to another
Okay.
urogyno on
Okay. But
Thursday.
how old were you when your symptoms began?
Oh, I wasn't young. Now more than ever, I never had really a flare in my life. I just had UTIs that were not UTIs. I had the worst flare about 3 months ago that I've never had in my life.
Okay, and describe that flare for me.
It was that I thought at first it was a UTI, went for MD, went to urologist, went for UTIs, negative, blood in dipstick.
Okay, no. Okay,
negative.
now wait. Don't tell me what they did. Describe your symptoms. What were your symptoms?
Oh, just awful pressure. See,
Where?
pain.
Okay.
Not pain. Just pressure,
Where?
urgency. Just
Where? Where
well, I
was the
didn't know.
pressure?
I didn't know if it was bladder or vaginal. I still don't till this
Okay.
day.
Okay. So you had pressure, and
Urgency.
urgency. Did you have pain?
Not pain, but just totally miserable and uncomfortable to make an appointment with the urologist.
Okay. What made it worse?
I had a burning.
Okay.
No burning at all.
No burning. Okay.
Okay.
Was there an event that you associated with the onset of these symptoms? Had you been traveling?
Well, I never really followed an IC diet, even though I went for pelvic floor. But prior to all this, I was having a lot of sauces and chilies, and I think all that really caught up with me. It was like, wow, that feels good. Okay. And I think all of a sudden I hit rock bottom. And one day I woke up and it's like, what the hell's going on?
So it just may be that your estrogen level finally dropped to a point that your bladder started screaming at you, and you were doing things you weren't following the diet. And think about your elders. Like my dad is 98 and he can't do anything with lemon. He can't do anything with tomato anymore because as we get older, our body changes. And I hate to break it to you, girl, but your body and my body, are changing now. And so we might not be able to do some of the things we used to love simply because our body can't defend itself as well because of the loss of estrogen. So I would just have them look at your skin, look at the estrogen atrophy that you might be having. And they also need to check your muscles again, because the other thing that happens, of course, is that with the loss of estrogen, your muscles get weaker. And
how do they do that? How do they check your muscles?
They do a vaginal exam, and they just touch.
Really?
Yeah, they just touch muscles. It's a finger in your vajayjay, touching stuff.
Okay.
And
so should I tell them to do that?
Yes, absolutely.
Okay.
Absolutely. When you need to pee, can you start your stream right away, or do you hesitate 5, 10, 15, 20 seconds?
No, I start.
Well,
I do bladder training.
Why are you doing bladder training?
Because I was going like 19 times a day. The pelvic floor therapist got me down using a wand and everything else. So it's been okay.
Okay. Well, I think
it was awful.
Well, I mean, at least have the doctor, just check and see if your muscles are healthy or not.
Okay, I
That
sure will.
and if what the physical therapist has done has worked for you, then great, power to you. But just having
Right.
another person take a quick look, and if she says, "Yeah, your muscles feel good," then we're going to be focusing entirely on your skin and how that's affecting your bladder. Okay.
Okay. Thank you.
Okay, and just know too, the American Urology Association guidelines is a 6-step treatment protocol, and the steps are arranged with respect to the risk of adverse events. So we don't want you to do surgery until you do the easy stuff.
Right, right. Yeah,
And
I'm aware
so
of that.
step 1, water intake, diet modification, supplements, muscle relaxation. Those are the step 1. So, you could be a good candidate for one of these supplements, okay?
What do you think of Claritin for flares?
It's not going to help your bladder. It's not going to provide a protective coating for your bladder, which you would need with
Right,
estrogen atrophy. All it's going to do is
right.
reduce
Okay.
mast cells. So Claritin, might be slightly helpful, but it's not going to deal with any of the fundamental issues as far as I'm concerned.
Okay, thank you.
All right, hon. Nice talking with you. Happy New
You
Year.
too. Same to you.
John. Hello, John. How are you?
Well, still quite a bit going on.
Okay.
So
Have you improved at all in the last year, do you think?
Sometimes I have a
Okay.
tendency to get back into flares pretty easily. And my urologist for quite a while now has said, well, we could take out your bladder and prostate. He's actually willing to do it, but I'm not willing to go there.
Well, refresh my memory on your symptoms and
So
for the people that are listening also.
sure. So primarily, well, I have both bladder and urethral pain.
Okay.
Urethral pain and urinating, and it feels like it's kind of around my prostate. And I do have
Okay.
pain with filling.
Okay.
For decades, I had rock hard muscles, and through lots and lots of physical therapy, those have pretty well loosened up. But there's probably decades of damage that has not healed yet.
Okay.
And so I still can get periods of basically it's a burning, cutting, and stabbing feeling all at the same time.
Oh, I'm so sorry, dude. I'm so sorry. I mean,
And so
hmm,
so I'm seeing my urologist on Tuesday, and I'm going to ask him about PTNS
okay.
because I don't quite know what else to do. One of the things that's kind of becoming it is a really big problem is that all of the medications that I can take to help me make my bladder pain worse.
Okay. Like what?
And I have not found a single thing that I can tolerate. Well, it started out with hydroxyzine
Okay.
that will help with bladder pain, but increases urethral pain.
Hmm.
Probably through the anticholinergic effect. It's kind of what I'm assuming. Gabapentin will provide a little bit of pain relief, but it irritates my bladder at the same time, and it quickly overcomes the pain quickly overcomes the ability of the gabapentin to provide any relief. What I find with they're usually an irritant for my bladder.
Okay.
And so one of the other problems that I have is hypertension, and I need to be taking blood pressure medication. And there is not a single medication that we've tried that doesn't cause almost severe, unmanageable bladder pain. So it's complicated. It's really complicated.
Yeah, it really is. Did you try have you tried the PEA?
I have, and I didn't really notice that much, actually. If I'm not to irritate my bladder,
Mm-hmm.
I don't have pain all the time, but I have really significant urgency frequency. It's only if I'm actively irritating it through the taking of medications that get bad.
I know you've had hydrodistensions, correct?
Yes, I have.
What did they see when they looked in your bladder?
So they've never seen ulcers. They'll see petechial hemorrhages when it's stretched.
Okay.
But every cystoscopy that I've done, it looks perfectly normal.
Okay, so then we just show, okay, that's important then. So has anybody looked at your spine, where the nerves merge at L4, L5?
I don't know. I mean, I have had nerve blocks done for my pelvis, which of course provide a block for as long as the lidocaine lasts or whatever they put in.
Okay. So that's important information, because when we block the nerve, the pain goes away. So that you have a nerve-driven issue, correct?
Yes, and it's worse when I sit, and I can get that tight rectal feeling like a tennis ball, and I've wondered, and it's relieved when I stand. I have less pain when I stand, or almost no pain when I stand.
So so we're really looking outside of the bladder. We're really looking at muscles and nerves then.
Yes, I strongly suspect that all of my issue is pelvic related, and I've had literally years of pelvic floor physical therapy.
But were they ever able to figure out why your muscles were locked down so badly? Do you know why?
No.
Were you, as an example, when you were a kid, can you remember any bike accidents?
It's possible, but I honestly don't remember.
What about, were you a bedwetter?
Yes, and I also had problems with chronic constipation when I was really young, like 3, 4, 5 years old.
Okay.
Yeah.
Okay, so think about that little boy who he's having trouble going to the bathroom, and God forbid, were they might have been giving you enemas when you were young.
Yes, I had fleet enemas all the time, and I hated them, and they were very painful.
Right. And so so of course your pelvic floor muscles would have gotten tight out of fight or flight, right? You dreaded the package. As soon as you saw the package, you knew what was going to happen. And of course your muscles locked down, and this went on for some time, right?
Yeah.
And for years.
Yes.
So so it's explainable. It's certainly not in your head. You are a classic example of muscle trauma. And now what we've got is, what is the legacy of that long-term muscle trauma, as well as what is the legacy of that stress that you went through?
So I started having what probably was urethral pain when I was 5. That's the earliest that I can remember it, 4 or 5, in urgency frequency. So I've actually had it since then.
I wonder, so that was probably allodynia, right? That was probably, or just cross sensitization. The nerves in your bowel have been irritated, and eventually the nerves in the urinary tract also become irritated, which could potentially explain that. I wish that we could go back in time and fix what happened. We can't. We got to deal with the reality today. So this is what we know today. We know that your muscles were extremely tight, but you have been diligent and you have worked your ass off, and they are that much better now. Power to you. We also know that you still have pain when you sit that is relieved by standing. So we know you still have a bit of a pudendal nerve entrapment somewhere. And the question is trying to figure out where that nerve entrapment is. And having your prostate removed and all that makes no sense at all here.
Yeah.
That would just create more trauma.
Yeah, that's not something I'm interested in doing.
I'm much more interested in the mechanical issue going on. Now, of course, the other thing, now you got the book Breaking Through Chronic Pelvic Pain, right? And
Yes.
this whole
yes.
discussion of mechanical injuries. Do you have
Yes.
one leg longer than the other? Do you have a bad knee or a bad hip? You saw the study. I hope you saw the study this summer, which showed that 70% of the men with testicular pain had an underlying orthopedic issue. So have we missed?
Oh, I missed that because I do have that problem as well.
Yeah. So I have to wonder, do we have an underlying bony structure abnormality, which is constantly putting stress on your pelvic floor now? Because there is an area of your pelvic floor that is still tight because you still have the pudendal neuralgia.
Yes, I do.
Do you have any sciatica in any leg, left leg, right leg?
No, I do not.
Okay, so it's very centered then.
Yes, it is very centered. Yes.
What orthopedic issues do you have? Do you have a bad hip, bad SI, anything?
Well, I have chronic back issues. I've gone to chiropractic help for a long time. I have extremely flat feet to the point where if I use inserts, it hurts my feet too much, actually.
Okay, and so you read that whole chapter on the feet and how that influences the pelvic floor?
Yes, and I'm working on attempting to use inserts. I've tried both orthotics, custom made, and off the shelf.
Yeah, the custom made orthotics are very hard to get used to. I mean,
yes, they are.
They're very hard. They're very painful at first. You just got to slowly work your way into it. I use Spenco. Have you ever heard of Spenco inserts for your shoes?
No.
Let me go see if I have one. Hold on. Here we go. And my boots. So let me get this out. This might be so you can find it in so they're green or blue and they're and you can see that they've got a nice arch to them, but they also give quite a bit.
Okay.
So this might be I switched to these before I could use my orthotics.
Okay.
So they're called Spenco, Spenco.
Okay. So yeah, I will look into that. So I guess my big question at this point, assuming that there's still some type of pudendal issue, which I've suspected for a long time,
yeah,
of pudendal entrapment or irritation, what's the best next step? That's what I'm really struggling.
Well, it's all about calming nerves down and trying to help nerves heal. Were you able to take Elavil at all, the amitriptylines?
The problem that they helped, they caused other psychiatric issues.
Okay, it's possible, absolutely. So we would be looking at the anticholinergic medications. We would be looking at the Neurontin. But what Dr. Payne said in his subtyping system is this is where post-tibial nerve stimulation really would shine. And so doing the urgent PC, I think would be fascinating to see how you did with that. I predict you're going to probably tolerate it very well.
I'm sure I would. The issue is going to be if I can find somebody in my area.
Just call. Yeah. Well, number one, you can call the company that makes Urgent PC. They have a physician locator on their website. And if there isn't anybody close, the other thing you could do is reach out to acupuncturists because it's at the SP6 point. Now, there are people watching who probably don't know what the heck we're talking about. So 27 years ago, neuromodulation was first used for bladder issues, IC issues, frequency, urgency, etc. They were invented at UC San Francisco. It was InterStim, involves a surgical procedure where they implant electrodes at your lower spine. Another doctor at UC San Francisco was so upset by the trauma patients were going through. He was like, guys, you can hit the same nerve at the ankle and you don't have to do surgery. All you need is an acupuncture point. And that was Dr. Marshall Stoller who invented that. We talk about that on our website. I was in his group. I was sent to him. I walked into his office in agonizing pain. In fact, the very first thing he said to me when I walked into his office was, "You're in agony right now, right?" And I burst into tears. I was like, yes. He was the first person to really understand it. And I've shown so basically what they do. Oh, wait, this is my bad leg. I shouldn't be doing that. Hold on. Let me see if I can do it on this leg. Yeah, there's a good. Can you see? I don't know if you can see this black mark right there.
Mm-hmm.
So it's 3 fingertips above the ankle bone, although it's actually moved a little bit. And it's like 1 fingertip down from the bone itself. So the bone is right here. So you can see it's 1 finger down. So this is the SP6 acupuncture point. And so they basically just insert an acupuncture needle there. You have to finesse it a little bit. And then they attach an electrical stimulator to it. And so look for acupuncturists. They might be able to do it for you too.
Okay.
S is in Sam, P is in Paul, 6.
Okay.
Okay.
Sounds good. Thank you.
All right. Well, keep in touch.
Okay.
I mean, John, I've known you for some time now. You are the perfect example of a proactive patient determined to get better.
Well, I don't have a choice.
Well, and yeah, I know, but you certainly haven't given up, man. You're kicking
Yeah.
it, really trying to get to the bottom of this. And I applaud you for everything that you've done. And I think what's really important for people to hear here with John's case is that your bladder is healthy.
Mhm.
Your prostate is healthy. Yes, you have symptoms, but that's the good news in this situation. And that's the same thing that happened to me. Is my bladder? There's nothing physically wrong with my bladder at this point in time. And the fact that a nerve block turned everything off tells us it's a nerve. So I think the other thing I would want to know is I would want a CAT scan or an MRI of your lower spine just to see if there's anything else there that's going on. Okay.
Okay. Thank you.
Okay. Hey man, keep me posted and let me know what goes on with that. Okay.
Sure.
Okay.
Thank you.
Talk to you later. Happy New Year, my friend.
Yes. Happy New Year.
All righty. Let's see here. Now, I have forgotten who came in next. And so let's see. Let's go to Erica.
Hi, Jill.
Hello, Erica. How are you today?
I'm okay. I've been better and I've been worse.
Okay.
So my dilemma is, and I've actually spoken to you on the phone because I supplements from the IC network. I'm just trying to chip away at my symptoms. So I got diagnosed. So I'm 40 years old now, and I started having symptoms about 6 years ago.
Okay.
My first urologist did not do a good job at all.
Okay.
Diagnosing me. He described it as a urinary condition.
Okay.
So, needless to say, he would, as all doctors are, he was just, he gave me the IC diet, sent me on my way.
Okay.
Fast forward now, I got on installations. I mean, I've had it all. I mean, when I say I've had it all, I've seen all types of doctors, pain management, chiropractor, own version of what's going on. Nothing has really helped me.
Okay.
However, 3 months ago, I started taking DH Aloe.
Okay.
That is the only thing that has alleviated my symptoms.
Awesome.
So that's some good news there.
So the fact that aloe, which is really a bladder wall calmer, soother, protector, that tells us that it's your bladder wall that's driving your issue in the first place. How old are you, hon?
I am 40 years old.
Okay. And have you had a hysterectomy?
No, I have not.
Okay. And you're still having normal periods?
Yes.
Okay. Were you, go back in time. What do you think triggered your symptoms?
Well, this is what confuses me. So I was a coffee drinker. I think mine was induced.
Okay. Okay.
And when I say food played a lot in it, but I also had a lot of antibiotic usage.
Okay.
I've had a lot of work done in my mouth. Growing up, I had a lot of throat infections. My mom never got rid of my tonsils. So I took a lot. And I mean, when I say like over abuse.
Oh, wait, hold on. Did I lose her? Hold on a sec.
Sorry, I'm here. I'm just seeing like other people in the screen. So
Yeah.
I don't know if they need to mute their buttons.
We're okay.
So, okay. So I have taken a lot of antibiotics in my lifetime. I mean, that is like the go-to. And I think I had my first UTI when I was like in my late 20s. I've had one UTI my whole life.
Well,
and it was, sorry.
Did they identify what type of infection it was? E. coli,
Well,
staph?
all I remember was, again, I went to my general doctor. I gave him my symptoms and he gave me a round of antibiotics.
And did it fix it?
And it went away.
Okay.
Yeah, they went away. That was, I would say, my late 20s.
Okay.
That was my only UTI ever. But again, as I got older, I started pineapples. I just started eating like a lot of pineapples. I wasn't like a big coffee drinker. I had like maybe one small cup every day. I consider that like a lot of coffee. Like I didn't drink a pot of coffee a day. But I did drink a lot of cranberry juice, a lot of tomato sauce, just a lot of acidic things. I was an avid black tea drinker, excuse me.
Right. And
So,
were you using artificial sugar, Splenda?
No.
Okay.
Although I do crave with sweets. I would say that is my arch nemesis, sugar. Like I love sweets.
So, I mean, a couple of different things come to mind in your case. I mean, number one, I think it'd be very, very interesting to have a next generation urine test because this all began with some sort of infection, and you've taken a lot of antibiotics, and I would have to wonder if there's any chance you've developed a chronic candida infection.
Well, I took the next gen test.
Okay. Oh, good. What did it find?
They saw a low. I found that it was like, that's what it said, low. Like there was a lot of, from what I read the description, there was a lot of like the bacteria that breaks down the food, the probiotic bacteria.
Okay.
Like there was some of that. There was no fungus detected.
Okay.
In the urine. There were about 6 things, nothing that really kind of jumped out at me. Like there was like no strep bacteria. It was like a very low bacterial load. So did it
identify any drug resistances?
Well, I see my urogynecologist this month. So in like 2 weeks, I see him just to go over the report. Now, it was my idea to have the next gen test. It wasn't his. He had never even heard of it before.
Okay. Well, I mean, it's data. It's data. I like data. I like facts, and it's useful. And so that showed no fungal infection, then that's really good. We can rule that out. Be curious to see what else is there. Just curiosity more than anything else. you are self-admitted that your diet was extremely challenging to your bladder, and our bladders were designed for life 5,000 years ago, where we did not the only acid we had was when fruit was in season that was unripe. And so consuming a lot of acid every day will eventually take a toll on the bladder. And so you could simply be a chemical injury patient. That's possible, but that we would expect that would be healing, that would start healing. And I think the good news
Right.
here is that the desert harvest aloe is working for you. And if the desert harvest aloe is working for you, then I would stay on the diet, because you're just not going to be able to go back to what you were used to doing. Stick on the aloe and let's just see if you got some healing happening.
Right. So I wanted to get your opinion because I want to know if my bladder is still in fight or flight mode, and what have you heard from IC sufferers?
Well,
because
the symptom of fight or flight mode affects your entire body, not just your bladder. And so, what's your anxiety level like?
Oh, my anxiety, I've always had not seasonal depression, I would say situational depression, and kind of like catastrophic anxiety.
Okay.
Where like loss of a job, a breakup, certain things like that. Just I noticed that I respond. It's like an old to certain things that happen in my life, and it's mostly based around fear.
Okay. So based upon they gave kind of here, let me get the magazine here. Hold on a sec. There was a way that they used to determine how wound up your nervous system is. Another way of calling it is wind up.
Mm-hmm.
And let me go to that real quick.
As other people have explained, I'm very sensitive to smell. I suffer from migraines also.
Right.
So I know that my nervous system is very sensitive. And sometimes even if I put even like a piece of broccoli, and I don't even know if this is possible, I feel it in my bladder instantly.
Well,
so I don't know if that's fight or flight, or does food actually get to your bladder that quickly?
No, food does
because
not.
In my case, it does.
It does not. Food cannot physically get to your bladder that quickly. It's physically impossible.
Well, I can eat. I've been on an acid-free diet for 3 years. I eat safe foods. I don't eat any sauces. I don't plan on ever drinking alcohol ever again in my life. I don't touch tomato sauce. I have a very bland diet, and I eat mostly from home. So I know everything I put in my food. And I just feel that now for 3 years, I've had 24/7 symptoms. So diet alone is not helping me. My bladder seems to look completely fine from the camera. They put a scope up my bladder and they're like, we see nothing, your bladder's fine. And I say, how could this be? I'm in pain. I have symptoms.
Okay, but we know why, because see, you are the perfect example of how I started this meeting. Okay, so symptoms are being driven by your central nervous system, not your bladder itself. Okay, and
how do I turn that off? And
well, you need to get our magazine. Get our magazine.
Yeah, I think I am signed up for it because I purchase your products often.
So but go download this magazine if you have a member page, or you can do it. But okay, so here, hold on a sec. Doctors can see how wound up your nervous system is by your outlook. Patients who feel like they will heal, view their world as safe, welcoming, and full of opportunity, have a normally functioning nervous system. Patients whose pain is not improved and are starting to feel scared are showing the chaos scene when the nervous system begins to wind up. These patients are bracing against pain, on edge, and not particularly friendly. And then patients who feel lost, alone, living in a dark, cold world are immobilized by pain and anxiety. Their nervous system has been wound up for a long period of time. There are other signs and symptoms of patients who are living with trauma and chronic stress, including anger, aggressiveness, defensiveness, hypervigilance, poor focus, sleep disturbances, being bossy, or a need for control, lack of empathy, increased anxiety, panic attacks, fatigue, fidgety, irritability, and in children, delays in reaching physical language and other developmental milestones. But there is hope. As Dr. Millspaw said, we need to calm and heal the amygdala and restore good brain functioning. So it's a complex issue, but I promise you that this article will blow your socks off. It's really going to help you understand what's happening here, and it's going to be focusing on calming your nervous system down, calming a lot of that down. So start with that, and you'll have some good, interesting things to talk about with your doctor. Okay.
Right. Yeah.
All right,
Okay.
hon. Carry hope in your heart, because I'm telling you, I've never been more excited than I am right now. I'm so thrilled with what I'm reading. So, okay, hon,
All right. Thanks, Jill.
and a happy new year to you too. Okay, so we're gonna go now to Lisa, but Lisa, I need to pee. So can you just give me a minute? I'll be right back, okay? You know, hey, listen, I've been doing this for 27 years. It's rare you're going to hear me say, I need to urinate now. Now I say, I just need to pee or I need a bio break. So give me a quick moment and I'll be right back. You know what? This brings up a very interesting point. Have you ever had stream envy where you've gone into a public bathroom and you're in one stall and somebody comes in next to you and they can just let it fly and you're sitting there, you know, squirt, 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 right?
Yep.
And
I get so excited those days.
well, you know,
I'm
and
able to when it happens.
but so for those of you listening to that, think about it this way. I mean, that's really a sign of tight muscles. You know, if you go in there and you just can't let it go, and I've been noticing for myself, like 10 years ago, it would have been couple seconds, stop, couple seconds, stop, couple seconds, stop. And now I can pee normally for like 20 seconds until it's empty. And I think a lot of that is because my pelvic floor is now much better. Well, listen, Lisa, how are you today? You look beautiful.
Thank you. I have a really complex situation that I'm in right now.
Okay, hit me.
Kind of life changing.
Okay.
I'm not going to get into the details about facilities and providers.
Okay.
But I am with the top 3 or 4, some of them in the country, and some of the top urogynecologists.
Okay.
And they pretty much said they've tried everything. Last week I had a 3-hour MRI CT scan.
Okay.
They were thinking it was something was going to show up. Nothing showed up. Some of the top ones pretty much said, sorry, we can't help you. But
Okay.
I think where it started was about 3 months. I've had these symptoms pretty bad for 15 years,
Okay.
but I was in a remission. Now, about 3 months ago, I got Botox injection,
Okay.
and pretty much my whole body fell apart. I
Okay.
couldn't stand. I couldn't do anything
Egads.
because my abs pretty much were shot. And my pelvic floor I used for years, allowing me to stand up and giving me the support. Now I need to pretty much start walking on my own. Getting trained on how I would get in and out of a bath. My urogynecologist said he's never seen this before. Pretty much, when do I say stop? Enough with the why. Let's get you feeling better. And
Well-
I am getting myself feeling better. I'm using 3 PTs in conjunction with each other that work with each other that do something a little different. My urogynecologist now said, what would you like to do? We'll try anything that you think might help.
But you're saying this all began immediately after a Botox.
Yes, and he's never seen this reaction. I can't find anybody that kind of can give me some kind of answer. Because if something's wrong, possibly it won't go away and I'll never fully heal.
Well, Botox.
That's what they told me at the Mayo Clinic.
I've worked
It's
with
complex.
so I've worked with one other patient who had a very, very severe reaction to Botox where it actually got into her bloodstream and it stopped her heart. And they had to resuscitate
Wow.
her.
I felt fine instead of, but not physically. I couldn't stand by myself. Now I'm trying to gain muscle tone in my stomach and my lower back, and I had pudendal nerve issues.
Okay, but wait,
So
but
I just got
okay,
a pudendal nerve block.
okay, but so hold on a sec, because I just really want to try to understand this. So when they did the original Botox, were they injecting your bladder or your pelvic floor? Where did they inject it?
Both. Bladder. When did they do it?
No, where did they do it?
About 3 months ago, if that was your question.
Yeah.
They did it in my vaginal pelvic floor, some in my bladder, because I have both issues, bladder and pelvic floor, and also a little bit rectum.
Okay. Did you
But basically
did
the
you
most
did you
in my pelvic floor?
so the 3-month mark is considered the mark where Botox, the effects of Botox start to wear off. Is anything starting to change for you? Is it starting to wear off for you?
No, but I actually have been in intense water therapy, so I can actually start to walk fully again. I can't bend down. I can't hardly do anything.
Are you
So it doesn't seem like it's getting better.
well, I think months are going to be the critical time here.
That's what they say. If I'm not able to get over this, it could be chronic for a lifetime. That's what
I'm just
gynecologist
not
said.
I've never heard I have never heard I have heard in all the reading that I've done is that Botox has a limited method of action and then it starts to wear off. I've never heard anybody say that it would cause like permanent nerve damage.
I went to a Euro move management neurosurgeon and UCI in Orange.
Yeah.
And he actually said the same thing, pelvic dystonia.
Okay.
And they actually said, why don't you go get a full MRI because something has to be neurological or nerve related.
Yeah.
And everything just came back fine yesterday.
Well, so then it goes right back to the Botox. So Hold on a sec.
Yeah, and I don't,
Let me
we
be
don't know what.
let me be a detective here. Hold. I wonder, so I think Botox is considered a medical device, isn't it? Botox therapy. Let's just see if the national database has.
I've been trying to research.
Hold on a sec. I'm just curious here.
But then my pelvic therapist actually agreed that's what happened.
Well, I mean, there's no doubt it's neurological. It's because after they turn your nerves off, you lost all this. You lost your function. So
Yes.
it's definitely neurological.
But then if it's coming back, maybe just the damage was done and now I'm healing. I don't know. I just want to make sure I'm okay with this. It's not making me nervous. I'm not in distress or fight and flight. I just want to move forward and do the best that I can do and heal myself the best that I can. That's my focus.
Well, I think what you need to do is you need to call the company. You need to file a report with the company, and you need to work with their patient assistants to see if they have any data of this happening. That's what I would do. Is I would
then go through my doctor, just do it on my own.
Well, I think both. The company is going to give you really important data here. You've got to start with the company. They've got to say.
Gotcha.
I'm just looking. I mean, I'm looking at the mod database, and it doesn't look like. Let me.
And if the best physical therapy says that they can't help you, they think it's nerve related.
Well, honey, the physical therapy would not help you if your nerves are turned off. Your Botox turned your nerves off. So I think you might have jumped on the physical therapy a wee bit too soon. But you're at that 3-month mark now where the Botox should be wearing off.
Right.
So I mean, there's no ifs, ands, or buts about this. Your nerves got turned off, and that's what happened here. And so and
they're probably turning back on.
Yeah, that's what happens with Botox. I'm just wondering. I would go over to FDA.gov and go through all the drug databases there, see if you can find any other information on this. But I think honestly, my first phone call would be to the company, and I think the company is Allergan. Allergan makes Botox. Yeah, and so let's go over to their website here for a moment.
Are they the only
Yeah, they have the patent on it.
Only manufacturer?
Yeah, well, they have the patent on it. So, yeah, go to Allergan.com, ALLERGAN.com. And you need
I'm familiar with them, yeah.
And you need to be working with their patient assistance line. It's just, and let's see, I'm just looking here.
And ideally, they would just give me more information about if they've seen it before, or what can I expect when I maybe speak with them?
Well, just say you've had a rare complication to Botox. It completely eliminated your ability to walk, and you need some guidance as to how you should be. Here, I'm just going through the drug safety sheet here. Here, hold on a sec. They've got a long drug safety sheet here. Most common adverse reactions: overactive bladder, UTI, dysuria, retention, overactivity, chronic migraine, neck pain, headache, spasticity, pain in the extremities, cervical dystonia, dysphagia, upper respiratory, neck pain, headache, increased cough, back pain, sinus pain, hemorrhage. You certainly should never have Botox again. You do know that, right? I mean, you've had such an extreme reaction here. A warning: distant spread of toxin effect. The effects of Botox may spread from the area of the injection to produce symptoms consistent with Botox, botulinum toxin. These symptoms have been reported hours to weeks after injection, with swallowing and breathing difficulties, can be life-threatening, and there have been reports of fatalities. The risk of symptoms is probably greatest in children. They have an antitoxin if they need, that might be interesting, except it will. However, the antitoxin will
Now,
not.
I do know of one more PT. Would it be worth calling them or kind of saying, okay, enough is enough already? But they kind of have a lot more information available.
Calling who?
Another PT clinic.
Well,
But they seem to have some information on this.
well, they might be able to rehab you, but ultimately, in the end, this is about trying to reverse the damage done by the medication. And so,
Yes.
you doing physical therapy is not necessarily going to heal a nerve. We don't know what happened in your case. So I think that I'm just going through the safety sheet
But
while
they're
we're
helping
talking.
me walk around better now.
Well, that's
I'm
that's
starting
important.
to walk around now.
That's important to try to get your muscles healthy again. And again, it might be that things are just slowly starting to wear off. So what they're saying here is a possible risk of irreversible effects are from chronic use. And was that the first time you'd had it done, or had you had other Botox? You'd had other Botox before that?
The first time.
Okay, well then this says that this is only relating irreversible effects to chronic toxicity. So you need to call the company, I think. I honestly, I think at this point in time, I would probably be working with an attorney, because your life was changed desperately. And if it does look like there might be some permanent damage, I think you might want to consider litigation in some way. I think I would
And
also.
now, if I do that, wouldn't some of the providers actually know about that? And it might
you're not
want to hinder them helping me?
Well, I mean, it's opening up a big can of worms, and you're not suing the doctor who did it, although it would be, and the doctor has told you that this has never happened before, but it at a minimum should be an important learning point for the doctor that clearly something he did, a location that he chose to inject you, is what began this process for you. And it would be interesting to get your case notes. It would be interesting to get your medical records, have another doctor look at the sites of injection to see if this doctor just screwed up and injected it where he shouldn't have injected it.
They did that already with my second opinion. That is fantastic. They already went through all of the MRIs, all out. My doctor did a map of exactly every location that he did at a point of the injection.
I mean,
so the second opinion looked at the diagram.
The other thing I think that would be really important in your case is I think your case is an excellent case study. I would love to see your case described and published in a journal to show other doctors what can happen with this. That's why, Botox was originally a step 5 treatment option. And the reason it was in step 5 was because it can cause urinary retention. They moved it to step 4 because they found that was dose dependent. And when they reduced the dose path, the risk of retention was substantially less. And that's why the AUA moved it from step 5 to step 4. But it would be interesting, I think, to look at the dosage that the doctor was using, as well as the locations, And I would certainly open up a case with the company and see if they have any information or advice on for you on how to restore some function here. But I also think that this is incredibly unusual, and I would want to know if mistakes were made. And if they were, I would be hard pressed not to want to push that a little bit further.
And if mistakes was made, that's why I went to go see the second opinion.
Right.
And she didn't find anything.
Okay.
So
Okay. So it just might be a very, very rare reaction, but I think your case would be an excellent case study for other people to learn from. So, hon, well, listen, I'm so sorry that you're going through this, but
I'm fine. I really appreciate you speaking with me. And
Sure.
I just want to find out more information. And thank you so much.
Well, go to
I really appreciate this.
On the Allergan website, I got their safety sheet. It's an 8-page safety sheet. I think you need to go through that too, okay? And the discussion about chronic symptoms was very bottom of page 6 on their safety sheet. You know what? Let me put the link in the. I'll just give you the link here. Hold on a sec. I'm going to, let's see. Okay, I just put the link in the chat window.
You've been such a big help.
Yeah. Good luck, hon. Keep me posted, okay?
Thank you so much. I definitely will.
All right.
Take care.
Happy New Year, hon. I'm going to wish the best for you. I'm going to say
You
prayer for
too.
you. All right.
Happy New Year.
Okay, I think we've got everybody
Bye.
on bye-bye on Zoom, so I'm going to shut that meeting down. All right, the Zoom meeting is now shut down. No, I don't want to update my system and reboot my computer. For goodness sakes, we're in the middle of a meeting. All right, so we're coming back now to Facebook and YouTube. And you guys, that really, her case, such an important case. And where you as the patient, I get very, very frustrated with patients who call me and who say, I've tried everything. Nothing worked. And it's like, well, what did you try? What did they do? And it's amazing the people who say, I don't remember. You got to track your symptoms really well. And you got to track your treatments really well. And if you're a member, we have a treatment tracker on our website that you can download. But I mean, you're the boss. You pay them. They don't pay you. You're the decision maker here. When you go to the doctor and you talk about therapies, you're supposed to not only say, okay, what are my options? But let's talk about the pros and cons, the risks versus benefits of this potential therapy. The American Urology Association created a 6-step treatment protocol that's designed to protect you. And she had the second worst Botox reaction that patients I've worked with, because one had her heart stop. Okay, so that was the worst. They resuscitate her. She's fine. She was in the ICU for some time, but you got to know the pros versus the cons. And it's always hard when a doctor says, hey, let's try this and let's try that, and let's try that. Or the doctor says, hey, I know it's exactly what's going to help. Y'all can't just say, okay, do it. You got to say, all right, let's talk about it. Tell me what it is, the pros or cons. I just want to do this with you guys really quickly. I want you to understand, and I want you to see the risk versus the benefits here. And, I can't really, hold on a sec. All right. So let's just take a quick look at these AUA guidelines, because they at least put treatments into context. If at your very first appointment, your doctor says, hey, let's do Botox, you're going to say, oh, hell no. So let's do this. So this was before subtyping, right? So subtyping is different. Subtyping has changed this, but this really applies to people with bladder wall issues, but you'll see a little bit more. So this is a 6-step treatment protocol that was created in 2011 and revised in 2014. And the reason why they did this is because there was tremendous diversity, dysfunctionality, whatever. I mean, patients were being treated in so many different ways. It was really difficult. Some doctors were telling patients there were no treatments. Other doctors were really good. Some were bad. Some did surgery. Tragically, some patients were crippled by surgery they never needed to have in the first place. And so the important point of these guidelines is consistency. They want doctors around the United States to be consistent in how they're approaching and treating IC patients. You can do this yourself if you go to auanet.org, American Urology Association. So auanet.org. In the upper right-hand corner is a link to guidelines. Click on the link guidelines. And then when you get to the guidelines page, search for interstitial cystitis. And you can go through it yourself. And for God's sake, print 3 copies of it. It's about 60 pages long. 1 page is for you to study. You got to read. You got to improve your knowledge level. 1 page is to give to your urologist because there are doctors out there who don't know they exist, even though they've been here for 9 years. And always keep 1 set in your car. So if you got to go to the emergency room or to another doctor, you can walk in with it. And so if somebody has the audacity to say IC is no real disease, you're going to say, well, the American Urology Association says different, and here's their here's their guidelines for it. The other thing that the AUA says is, listen, if a patient is not responding to therapy, if a patient is getting worse rather than better, for God's sake, stop and take a step back and let's revisit the diagnosis. Let's make sure we know what we're doing. John, who was in our Zoom meeting, is a perfect example of that. Okay, so John's bladder is normal. My bladder is normal. And yet we definitely had bladder symptoms. Why? Because we had an underlying muscle issue. And so the AUA is now really accepting the fact that a lot of us don't have bladder issues in the first place. Our bladder is the secondary victim of another issue. Okay, but in the AUA guidelines, 6 steps to treatment, arranged with respect to the risk of adverse event. They want you to do the easy stuff before you do the dangerous stuff. So what's in step 1? Step 1 is improving your water intake. Because, a lot of you are dehydrated and you're not drinking water. Okay, y'all know you're doing it. Y'all know you're doing it. You got to dilute your urine, 6 to 8 glasses of water a day. Your urine should be a pale, clear yellow. Number 2, diet modification. For God's sake, if you're not drinking water, you're only drinking Coke or coffee, it's your own fault. Your body is not designed for that, especially when you're older. So we got to try modifying the diet. You'd be amazed the number of people who, once they change their diet, their symptoms go away. Number 3, you can try supplements because we do have some good over-the-counter supplements now. Number 4, muscle relaxation, doing your guided relaxation. And number 5, acupuncture, right? Okay, so these are considered benign. We really don't see a lot of issues with this. Of course, with supplements, some people are sensitive to supplements. If you're aloe intolerant, you're not going to do that. Peora, PEA, the IC study showed no side effects. However, all of the chondroitin-based supplements have the potential of giving you a little bit of gut distress. So we generally tell patients to try 1 at a time, 1 capsule, see how you do, make sure you don't have an effect, and slowly work your way up. And so again, the supplements that we're talking about are going to be Bladder Builder, which is the top supplement right now. Bladder Rest. For people who are super, super sensitive, this is the one that we usually tell people to try first because there's no ingredients from China, very few ingredients, and it's really kind of a very pristine formula. In contrast, Bladder Builder does have a lot of other stuff in it, like probiotics and PEA and stuff like that. Then we have CystoMend, which is very similar to CystoProtect. Whoops. So CystoProtect was a top supplement for about 20 years, but they had an issue with a cancer warning, couldn't get it for quite a few months, for almost 10 months. And other companies stepped in and tried to fill the back. CystoMend is kind of the newest one. So it's basically this formula with the addition of pumpkin seed extract. But man, if CystoProtect's working for you, power to you. go for it. Sister Renew is another one. Whoops. Sister Renew is chondroitin with a little bit of aloe, a little bit of lemon balm for a nerve calming effect. Okay. If anybody has any questions on those, I'd be happy to help you. All right, let's go to step 2. So if the supplements don't work for you, the next thing the AUA says is, all right, if your muscles are tight, let's try some physical therapy. We can try some oral medications. So in this would be Elmeron. Again, if you've got a bladder wall deficiency, or they could do the amitriptyline, the Elavil, if they're trying to calm nerves down, hydroxyzine, also known as Atarax or Vistaril. Our challenge with the oral meds is pretty much the oral meds have now been linked to issues. Elmeron is now linked to retinal disease. And the challenge with the Elavil, the amitriptyline, is that as an anticholinergic, that we now know anticholinergics, if used daily over time, can lead to cognitive decline and dementia. And so, they're saying if you take it every day for 3 years, your risk of cognitive decline goes up substantially. So again, yet another reason to try the supplements first, because we don't see those side effects with those. Also in step 2 are bladder installations. And please, God, do not let anybody put anything in your bladder unless you know what it is and you've talked about it. In the old days, they did bladder strippers. They did chlorpactin and silver nitrate. Agony. They're not even mentioned in the guidelines anymore. That was back when they thought that this was a bladder wall issue. So the theory was to strip the bladder lining off completely and hope that a new healthy bladder lining will grow. Of course, now we understand that IC is injury and for many people and estrogen atrophy. The last thing we want to do is strip the lining off the bladder. So generally, the only bladder installations that are used now are going to be rescue installations, a heparin lidocaine installation or an Elmeron lidocaine installation. Some doctors are still doing DMSO, but DMSO has been on its way out for some time. Some people, they say there's wiggle room, there's a little bit of place for DMSO. But DMSO also is associated with some significant side effects, such as a garlic-like smell. And early studies showed that it could cause irreversible bladder spasm or muscle spasm. So, yeah, I did 8 DMSO treatments, did nothing for me. I don't see it. Of course, now we know why, because it wasn't my bladder, it was my muscles. Okay. So let's say you've done all of step 2. It's time for step 3. What's in step 3? Well, step 3 would be doing a hydrodistension with cystoscopy. Because if they stretch your bladder, what that does is, number one, well, it gives them an opportunity to look closely at your bladder wall. That's important. I mean, listen, if you've had symptoms for 3 to 6 months and you're in pain and you got blood in your urine, well, for God's sake, yeah, you probably want somebody to look in your bladder and see if there's anything funky going on there. Could you have bladder stones growing out of your bladder wall? Could you have Hunner's lesions? Hydrodistension, though, has a therapeutic effect, although it's really not used so much anymore. When you stretch the bladder, well, that does temporarily break the nerves in the bladder wall. And so patients notice that they feel better after a week or so. And that's because the nerves have been broken. So you don't feel the pain or you don't feel the frequency urgency as much. The challenge, though, is that they do grow back. The nerves do grow back. And sometimes more nerves grow back. And so it's pretty rare to have repeated hydrodistensions. There's some patients who do. In fact, Donna, who works for me, is one of those patients. She's in her 80s now, where the hydrodistensions really were meaningful for her. But they're done in the operating room. They come with the risk of using anesthetics, et cetera, and anesthesia. So that's why it's in step 3. And Hunner's lesion also, the minute they find Hunner's lesions, they're supposed to treat them. So even though they're in step 3 here, the AUA guidelines say if you identify them early, treat them early, because Hunner's lesions do not respond to Elmeron or other therapies. Hunner's lesions need lesion-specific therapy. And now at this point in time with the virus research, I would want a next generation viral test to see if they can find a virus in there that might be doing it. And maybe an antiviral therapy would be appropriate. That's very new. So what's in step 4? So let's say you've done everything and now you're ready to move on. In step 4, we have neuromodulation. So we can do urgent PC, which is done at the ankle, which doesn't require any surgery, or interstim, which does require surgery. Interstim has thousands and thousands and thousands of severe adverse events reported to the FDA, including fatalities. The last time I counted, there were 19 or 20 fatalities. So we don't necessarily want to start with interstim. We want to start with urgent PC, which is just a freaking acupuncture needle stuck into your skin. No surgery, no long-term lasting effects. I was in that group. I praise God, hallelujah. When I was referred to UC San Francisco, I ended up in Dr. Stoller's clinic rather than Dr. Schmidt's clinic. Otherwise, I would have had interstim. Holy hell. Was I lucky. And so the ankle neuromodulation, by week 3, I had my first 2 hours without pain. And by week 7, I had my first day without pain. And so the ankle stimulation, urgent PC is worth looking at. And of course, we can also see now here that Botox is in step 4. And Botox, as we just learned, the big risk of Botox is that it basically turns off nerves for a period of time. So it can turn off some of those pain nerves and those frequency urgency nerves. But when they do your bladder, they're just doing kind of random locations, right? It's not like they know exactly where to do the Botox. Your nerves are kind of a spider web that go through the bladder wall. So they have to do a lot of little injections all over the place. And if you're lucky, they hit the right nerve. If you're unlucky, they hit the nerve that controls your ability to pee, or your ability, in her case, to walk successfully, although that was because her muscles were immobilized. So interstim has issues. In step 5, we have one treatment, cyclosporin. Cyclosporin works on the immune system, and it is considered a bit of a miracle drug for the doctors that are using it. It has helped a tremendous amount of patients. The challenge is it also has a tremendous amount of side effects. It can cause high blood pressure among them. But one of my dearest IC friends had extremely severe IC, and yet she was still working and is still working as a high school teacher, or she was a teacher, and she was doing bladder installations in school, to try to get through it. That woman is a hero to me. She loved teaching. She was going to do it, even though her symptoms would have sidelined me for sure. And she had gone through everything. Nothing was working for her until they put her on cyclosporin. She's now off all of her pain meds. She's off everything. And she's been using cyclosporin successfully for 3 or more years. The biggest risk with cyclosporin is it depresses your immune system. And so it makes you more vulnerable to other things. But cyclosporin, when you talk to the top guys working with IC, they really think of it as a bit of a miracle drug for the more severe patients. And so in my friend's case, it's absolutely changed her life. And I spent years talking with her when she's been crying, and she hasn't cried for 3 years. I mean, it's wonderful. And then the last step in the AUA guidelines for IC is surgery. Why? Because surgeries are irreversible. So we're going to put them in the last step. Surgeries are extremely rare in the IC patient population. They're really the only time they're going to consider doing it is if your bladder wall is profoundly damaged and or shrunken. So remember, your bladder is a hollow organ that stretches as it fills with urine, and then it compresses. If your bladder's lost the ability to stretch and it's basically the size of a walnut, that's about the time they start thinking about doing an augmentation, where they might try to expand it with a little piece of intestine, or they might consider a cystectomy. One of the patients that I worked with, again, early on, a very interesting case. She developed really severe IC symptoms as a teenager. I mean, like really bad. And she was just crying all the time and, obviously desperate for help. And to the point that they just thought it was a mental illness, right? I mean, it's just like, hon, you're just really emotional here. There is just something going on mentally with her. And she finally found me, I don't know, when she was like 22, 21, 22 years old. And, I have to admit, the first time I talked to her, she was insane with pain. And I had to wonder too if there was some sort of underlying mental abnormality going on. But they finally opened her up. They finally did exploratory surgery. And you know what they found? Was her bladder was completely destroyed and ruptured because she had been in a car accident in her early teenage years and they missed it. And her bladder was destroyed and it was leaking urine into her belly for more than 5 years. That girl was in agony. No wonder she was emotional. No wonder she was crying and hysterical and begging for somebody to help her. Her bladder was destroyed. And yeah, they took out her destroyed bladder. And it's a journey. It's having your bladder removed is rough. The other patient that comes to mind is a patient who had she was a 32-year-old patient with urethral cancer from HPV. She had a really wicked human papilloma virus infection. And some strains of HPV, I think 8 or 9 strains of HPV have been now linked to cervical cancer and vaginal cancer, uterine cancer, and obviously throat cancer. I think Farrah Fawcett Majors, who had throat cancer. And I'm pretty sure that was related to, I might be wrong, but I think that was related to HPV. Well, she got a viral cancer in her urethra. So they removed her urethra, her bladder, and they did a total hysterectomy. Man, they removed everything out of her pelvis that they could remove because of the HPV cancer. And then, nobody told her about the recovery. They were like, 6 weeks, you'll be fine. It's like, no, it's a year minimum to recover from having your bladder removed, just like it is a year to recover from hysterectomy completely. And so I begged my doctor to remove my bladder when I was 33 and this all started. And I praise God that he did not do that. He would not consider that because it was never my bladder in the first place. Okay. All right. So let's take your questions again. I'm still feeling pretty good here, but hold on a sec. I have lost my YouTube page. Oh, there's my YouTube page right there. Sorry. I had my Facebook page over my YouTube page. Let's see here. What have I missed? Julie says, I feel like I'm living this nightmare I call IC, but my parents did call it. Julie, hun, listen, you came in late. I hope you'll watch the beginning part of this. We have had a huge breakthrough as to why patients get pain, different pain conditions over time. And believe it or not, it relates to brain function and being in a constant state of fight or flight. And we now know how to break out of that. We now know how to calm the brain down. And so my issue of our magazine, our fall winter magazine, I did a big double issue, catch up, talks about chronic overlapping pain conditions and what to do. And it's extremely exciting. And so, and the other thing we got to remember here is, listen, we can't change the past. It's over and done. We can't worry about the future because our worry has no control over the future. What we have today, we have this moment at this time. And that's where we need to focus our time. We need to be mindful about what is happening right now at this moment and what can we do to relax muscles, to reduce anxiety, to eat well, et cetera, et cetera. You know what I mean. All righty, let's go to Facebook here. Somebody again asking about the Mayo Clinic, and I just got to say, historically, I would not go to the Mayo Clinic. I just was talking with somebody else last week who went to the Mayo Clinic, was treated terribly. I had a guy who called me, a very wealthy guy, extremely wealthy guy, who went to the Mayo Clinic for prostate cancer, and they cured him. So his wife came down with IC, so she took him to the Mayo Clinic, and they were stunningly disrespectful to her in Minneapolis. And he called me from the private jet. We're talking super wealthy guy. And he's like yelling over the phone, I can't believe the way they treated my wife. Where can I take her? And I referred her to a pelvic pain specialist. So again, we're talking Ken Peters at Beaumont Health, Robert Evans at Wake Forest, Robert Moldwin up in Long Island, Phil Hanno out here in California, Chris Payne out here in California. We're talking top tier IC pelvic pain specialist. Robert Eckenberg in Philly, Bethlehem, Pennsylvania. Robert Eckenberg would be a great choice. He also practices, I think, he has a clinic in New York one day a week. Becky says Peoria has been great for her, and she has tight muscles. That's good. Good to hear. Why do I'm down to my last pair of glasses. This is my last pair of glasses. I am not ready to go to Costco where I get my eyes examined. I have not been in Costco in 10 months because of COVID, but I really need to get new glasses here. Dina says, is IC passed on genetically? My daughter's having problems. Sensitivity can be passed genetically. So if you're a redhead, right? I'm a redhead. Redheads are known for, blondes, known for having sensitive skin. So my mom has this. My sister has this. My grandmother had this. My great-grandmother had this. So inheriting that sensitive body is absolutely possible. And Dina says, yes, she was a gymnast. Dina, I'm sorry, man. I'm catching up on stuff now. Alice says, just started the elimination diet after my diagnosis in November. Dropping coffee has been so hard. The surgeon was checking for endo and IC, but only found IC. Doing weekly bladder installations, and you're on the diet. Looking for hope. Girl, awesome. Sherry says, I want to order some Peoria, but it says it's out of stock. You know what? We should. They were just making it last week, and if it should be on the way to us right now. Happy New Year, Dawn. Thank you. You tested positive for mycotoxins. What do you know about mycotoxins in IC? So, guys, we did a story on this. It was a very interesting case of an IC patient diagnosed with IC who was not responding to any therapies. And incidentally, they discovered a massive water leak in her house. And she had black mold in the padding underneath her carpet. Huge black mold infestation in her house. And it turned out everybody in her family was sick with a variety of symptoms related to mold. We later did an article on it in our magazine. Here it is right here. Well, it was a year ago. Could mold toxicity cause IC symptoms? And the answer is hell yeah. Absolutely. Absolutely. And here's the article right here. I would absolutely encourage you. So this is our our winter 2020. So this was a year ago. So get this. And I know I've talked with a couple of experts. Getting rid of mycotoxins is a long process. You have to work with a specialist who can slowly help remove those from your body. Sue couldn't get into the Zoom. I'm sorry, hon. I don't know why. I just know that when I'm in Zoom, I don't see comments. Laura says she's been using Desert Harvest Aloe for 30 years. Always made the biggest difference for me. Awesome. Happy to hear it. We have Desert Harvest Aloe. The 3 products that contain aloe are going to be Desert Harvest Aloe, Aloe Path, which combines aloe with PEA, and then Sister Renew has a little bit of aloe. I think my biggest challenge with aloe is I want a little bit more data on safe dosages over time. I was looking for data earlier this year and I couldn't find any. Casey says Irvine is on a high COVID high alert. Yeah, we all are. It's ridiculous. California's messed up. Judy, thank you for the 150 stars. I really appreciate that. Happy New Year, Sherry. And thank you for sending stars. Elizabeth says, so having a total hysterectomy, ovaries removed, getting no estrogen therapy can damage the bladder? Yeah, absolutely. But it's not, I mean, listen, normally when you have a hysterectomy, they do a hydrodistension anyway, very quickly to make sure they didn't puncture your bladder. I worked with one patient who, after her hysterectomy, suddenly came down with urinary symptoms, and it was a result of a stitch from the hysterectomy that had perforated her bladder. And once they removed the stitch, her bladder healed. So hysterectomy can physically damage the bladder, but it's the estrogen loss that's going to take a big toll on the urinary tract as you get older, because your bladder uses estrogen to produce that nice thick coating of mucus. We call it the mighty mucus, that acts as a barrier to protect the cells of your bladder from any toxins in your urine. I mean, the bladder is the only organ in the human body designed to hold toxic waste for an extended period of time, because urine is body waste. It contains ammonia and urea and all sorts of chemical irritants. If you have a smoker, if you've been painting, anything, that all ends up, byproducts all end up in your urine. So if you think about it, how can the bladder hold ammonia for hours at a time and not get hurt? And the answer is, this is like your mouth. It's a hollow organ covered with a thick coating of mucus. And that mucus is a structural barrier that repels urine and keeps it off of your skin. Unfortunately, that barrier is estrogen dependent. So when you're young and you have lots of estrogen, you have lots of mucus, and you can get away with a lot of stuff, like drinking diet soda. When you're older, you have much less estrogen, you have much less mucus. Thus, your bladder's ability to defend itself is now compromised. It cannot defend itself as well. And that's why some women get very frustrated, because in their 30s and their 40s, man, they love that cup of coffee or sweet tea. And all of a sudden in their 50s, bam, it hurts. And you think it's infection. It's not infection, it's estrogen atrophy. So normally, if they see that you have estrogen atrophy, and I would encourage everybody to search for genitourinary syndrome of menopause, genitourinary syndrome of menopause, so that you can learn about the symptoms that happen as you get older, because they don't educate us well. And believe me, it comes as a surprise. So generally, once they start seeing dry skin, a dry vulva, sensitive, you've got burning on the outside as you're peeing, that's usually estrogen atrophy on your vulva, they will give you a topical estrogen cream. And what's nice about that is that your skin immediately starts using that to produce mucus. Unfortunately, some women stop it because listen, if you're dry down there, anything you put on it is going to hurt at first, because there's no protective coating. So normally, if the drier you are, the more burning estrogen cream will cause. But every subsequent time you use it, it gets less and less and less. Why? Because your body is using that estrogen immediately to produce mucus. You got to kind of get through the first 2 weeks. There are a lot of women out there, to use estrogen, it burns like hell and they flare, and that scares them and they stop. And what happens is you just get drier and drier and drier, and it's only going to get worse and worse and worse. So don't be afraid of the pain, but it's not pain, it's burning when you start using estrogen cream. That's really a measure of the health of your skin. Now, there's one qualification to that, and that is Premarin. Premarin is a very popular, very expensive topical cream that is often given to patients because it's covered by insurance. It comes from pregnant mare urine, pregnant horse urine. And because it is a big brand name, they put a lot of preservatives in it to expand its shelf life. And Premarin is well known for causing a lot of extra burning. That certainly caused burning for me when I tried it. And I tried it in my 30s or my 20s for vulvodynia, something like that. We do better with a compounded preservative estrogen cream. So I get mine from the Women's International Pharmacy in Arizona. They're a mail order pharmacy. Never had a flare from it. If I don't use my estrogen cream for a couple of weeks, the burning comes right back. The heat comes right back. And so that tells me how good I've been. And I tend to be a little passive aggressive with my estrogen cream. I just forget it. Andrea has joined us from Chile. Saludos desde. I hope I pronounced that right. Mele says, what are you doing for your muscle spasms? I have chronically tight muscles and awful pain after BMs. Pelvic floor physical therapy combined with a skeletal muscle relaxant like baclofen, Flexeril, or Valium. Often they will give you a vaginal Valium suppository. You got two different types of muscle groups in your pelvis. Your organs, like your bladder, are composed of smooth muscle. So if you're having bladder spasm, so as the last couple of drops of urine are coming out and you get the strong bladder spasm, they have to give you a smooth muscle relaxant, and that's going to be Detrol or ditropan oxybutynin. But if it's your pelvic floor that's spasming, that's skeletal muscle. And so skeletal muscle will not respond to a smooth muscle relaxant. You have to use a skeletal muscle relaxant. That's baclofen, which is great to use during the day because it's non-sedating. Flexeril, also known as cyclobenzaprine, or Valium. And Flexeril and Valium can be sedating, so you don't take those during the day. I take a quarter of a Flexeril at night. I've been doing that consistently for the last couple of weeks because of the muscle tension in my leg from sciatica. John says, or I think it's Loretta. Loretta, I tried one capsule of bladder rest and had violent burning of my esophagus, stomach, and bowels. Is this unusual? It is unusual, but it's not surprising. That tells us that you are sensitive to one of the ingredients, and so you just can't use it. You're not the only person that it's normally not violent. It's normally just a burning sensation or loose bowel. So I am so sorry that happened. And Loretta, have you tried the aloe at all? Because the next step would be the aloe, but the aloe is even more notorious for causing gut distress than bladder rest. Bladder, it's very rare that bladder rest causes an issue. That tells me you've got a strong sensitivity. David says, can we have something free? Are you asking me for a freebie? Really? Sure. Okay, so I have got a bunch of issues of our magazine. So if any, well, not this one, our current magazine. And so I am going to give these away. So all I need you to do, if anybody wants a free copy of our magazine, you can email me icnetwork@mac.com. icnetwork@ M as in Mary, A as in Apple, C as in Charlie.com. And if you mail me your mailing address, I will snail mail you a copy of our magazine. Honestly, I think it's the best issue I've ever done. I worked 2 months on it. And And I think that especially if you have chronic overlapping pain conditions, there's also an update on flare management tips for the new year, giving you a preview of a new book on IC that's coming out shortly. So I've reprinted part of the chapter on flare management. So there's an updated guide on flare management in here. icnetwork@mac.com. Send me your mailing address. I would be happy to do that. Sue says, hey, and Loretta, would you, Loretta, email me? Would you email me? I'd like to talk to you a little bit more about the reaction you had to bladder rest. We want to definitely let the manufacturer know that that happened to you. I'd like to know a little bit more, and I also definitely want to give you a refund, okay? For sure, 100%. Jill says, would you be able to give me the name of an IC pelvic doctor in New York and Pennsylvania? You can find their phone numbers on our website, icnetwork.org. icnetwork.org. Just go to our doctor finder, the 2 doctors to look at. So the cool thing about where you are, Jill, is in New York City, you got some of the best physical therapists in the world. You've got Isa Herrera at Renew Physical Therapy, and then you've got the other one, and her name is on the tip, Amy Stein at Beyond Basics Physical Therapy. Outstanding pelvic floor physical therapists who have written wonderful books. And also you've got Dr. Robert Eckenberg, probably the leading pelvic pain doctor in the United States, who practices out of Bethlehem, Pennsylvania and New York City. Elizabeth says, can starting estrogen then heal your bladder? Only your bladder can heal your bladder. So no product can heal your bladder. What's going to happen is estrogen is going to give your bladder an essential ingredient to produce that nice protective coating. Sue says, I've had 3 recent bacterial UTIs, treated at urgent care with 3 different antibiotics, still having symptoms. They told me the last test was negative, sending me to a new urologist January 27. I don't know how to tell if I have a flare or UTI and have no idea what to say to the new urologist. I'm miserable. As soon as the antibiotic is finished, my symptoms come back. Well, number 1, Sue, I would, before that appointment, see if you can have a next generation urine test. A next generation urine test will look for good bacteria, bad bacteria, fungi, and more importantly, it will identify if you have a drug-resistant infection. So go to bladderhealth.org, bladderhealth.org, and you can watch a bunch of videos on that. You order the test yourself. It's $199. It's the same testing they use for COVID, next generation DNA testing. They send you the kit, you pee into a cup, then you extract a little tiny bit of it. I even have a kit over here. And then you need to get a doctor's signature. Your primary care can sign it. You just fax them a piece of paper or just run it down to their office and see if they'll sign it for you. If they won't sign it, you can call the company Microgen. They have doctors almost everywhere that will work. I would want to know what type of infection it is and just get that basic foundational information. And then I think you need to walk into the urologist. And again, you know, what I say is don't just say you got IC right away. I don't think that that's helpful at all. Describe your symptoms. You know, say, listen, I have extreme frequency, urgency. They thought I've had infections. Whenever I stop the antibiotics, the symptoms come right back. When I'm on the antibiotics, the symptoms go away. When I go off of them, the symptoms come back. You might even want to consult with an infectious disease specialist. Debbie says, what are the names of topical estrogen creams that are not Premarin? Usually it's just an estradiol cream or an esterase cream. Loretta says, how about plain chondroitin with no additives? You can, Loretta, call me. You know what? Call me like on Tuesday or Wednesday. Let's just go over it. Let's just I'll try to do a little bit of brainstorming for you, and let's see what we can figure out. The challenge with getting chondroitin, just a plain chondroitin, is that chondroitin comes generally from 2 sources, from cow trachea or shark fin. Cow trachea is banned in the European Union because of the risk of mad cow disease. So where do they send their cow trachea? To the United States, where we happily will take it despite the risk. So cow trachea is not ideal. Shark fin, of course, is disgraceful. We also don't want to do shark fin because it's decimated shark populations. They cut the fins off and throw the fish back, and the fish can't swim, and it's a terrible way to die. We're not going to support that. So you really want to look for a chondroitin that's sourced from chicken. That would be ideal. Elizabeth says, are there any specialists in Chicago? Go to Loyola Marymount. Has done some IC research in the past. There are 2 female gynecologists who have done that. I don't remember their names right now. That would be a place to start, would be Loyola Marymount. And I think that Dr. Anthony Schaefer, I don't know if he's still in practice, would be interesting. Eric says, hi, Jill, doing well. Solved some of my pelvic mysteries and would love to share with group at some point. Tell us, hon. Let us know what it was. I'd love to hear what was going on. Becky over on YouTube says, bladder rest didn't work for me either. It caused an IC flare, but Peora works great for me. So I'm happy. Yay! You know, I mean, we're also individual. Finding it's trial and error. In many cases, it's trial and error. And that really reflects the great diversity in this patient population, right? A one treatment fits all approach does not work in the IC patient community. No doubt about that. Eric, if you want to tell us a little bit more, that would be great. Allison, thank you. I see your email right here. I want to say that you guys, if you're ever in a meeting and I say I was going to send you something and you didn't get it, that means I didn't get your email. There was a lady who I was going to send our Echo egg to, and I couldn't find her email and I couldn't send it to her, and I feel so bad. So Eric says, by the way, Dr. Schaefer did my first cystoscopy. Your issues are more central sensitization related. That's how we began this whole meeting, Eric, is we talked about all the new discoveries with that. Now, are you better? What did they do for you? Mine are CSS too. Mine are CSS and muscle related for sure, 100%. Eric, hey man, dude, send me an email, icnetwork@mac.com, and I will send this to you, because the whole first half of this magazine is dedicated to the central nervous system, specifically on how to turn the amygdala off in the brain. That patients who have chronic pain disorders, generally what we see is a brain living in fight or flight. The sympathetic nervous system is not turning itself off like it is supposed to turn it off. And so we go through that. Katrina says, can desert harvest aloe cause digestive upset? Yes, absolutely. Any aloe can cause digestive upset. And so when patients call us and they ask about aloe therapy, the very first thing I say is, have you ever tried aloe before? And if they have, and it's given them stomach upset, then yeah, then aloe is kind of off the table. Aloe is well known for it. Yes, Eric says, and the brain was sensitized. Yes, exactly. That's what my whole article is about. I attended a class, I attended a 3-week International Pelvic Pain Society meeting that talks specifically about how the brain, specifically the amygdala in the brain, is at the core. Okay, that's my email address. You need to send me your mailing address or email address at icnetwork@mac.com, and I will send you this magazine. You're going to love it. Yes, that is correct. icnetwork@mac.com. Yeah, looking forward to it. I think you're going to love it. I think you're going to love it. I was so excited to see the data. I mean, I was just so incredibly excited that we finally have an answer as to why these chronic overlapping pain conditions. You worked with a great pelvic pain physical therapist in Rochester, affiliated with Mayo? That would be one of the few success stories we've had from Mayo, if they were. Let me just do a preview. Okay, so in this magazine, just so you know what we're talking about, the articles are, the first article is on chronic overlapping pain conditions. Here, hold on. Phone number for the IC Network's on our Facebook page and right on the top of our website, icnetwork.org. Other articles in this magazine are birth control and how birth control can affect IC. We have an article on Ehlers-Danlos syndrome, which is a confusable condition to IC. We have a whole section, refresher on flare management tips from a new book, Managing Medical Costs. And then my dear friend Chris has written an article on IC, obsessive compulsive disorder, and autism. Chris, if you're here, thank you. Dude, you are a wonderful writer. We go through some winter favorite recipes, and we have a patient story on water and what's new in the IC store. And our resolution, this will be my healthiest year ever. It's a little hard to fathom with COVID right now, but hey, man, isn't the joy of support groups? Because we're here for each other, we educate each other, we lift each other up, we help each other, we empower each other, and we are going to get through the next 6. I mean, listen, we got to be blunt here. It's not going to be until next fall that things get normal, provided enough people get the vaccine. But we can do it. We've just gone through a year. We're going to get through another 6 months just fine. You've got great skills, and we're going to do it together. And you're going to see me doing meetings every week, if not more. I keep saying I'm going to do more, and then things happen. Like I'm getting my new front teeth tomorrow. So I fractured both of my front teeth at the beginning part of December. At night, grinding my teeth. They were fractured. Eric says, we used a great book found on Amazon, Why Pelvic Pain Hurts. I think we sell that book. I think we do. Let me see. Hold on. Oh, no. This little book, When It Hurts Down There, by Dr. Angie Storr, is fabulous. I love this book because it talks about pain processing, and it explains really well how, like, this is a fantastic picture because this shows that all the nerves in your pelvis end up merging in the same area of your spinal cord. And that helps us understand why when the bladder gets irritated, the bowel gets irritated. And when the bowel gets irritated, the bladder. Eric, send me the info on that book. The other book that I'm in love with is Breaking Through Chronic Pelvic Pain by Dr. Jerome Weiss. And this is really the book for people with muscle issues, injuries, traumatic injuries, mechanical injuries, things like that. You like my snowman, huh? And we have to thank our sponsors for these meetings. Preleaf, DSE Healthcare Solutions. We have to thank them always for sponsoring these meetings and helping me pay a few bills. Preleaf is also known as calcium glycerophosphate. It helps to reduce acid in foods that you might be eating so that they're less irritating. And so Preleaf has helped a lot of people eat a more balanced diet. Eric says that book covers a lot about the nervous system. Hey, man, when you email me, could you please give me the details on that and the name of the author so I can get it? I would love to read that. I am just revved. I'm so excited. And I just think that, listen, my life has not been normal. And it's been painful at times to think about the things that I lost because of my early injuries and illnesses, like having children and having grandchildren. And as I get older, that's more and more painful at times, that I see my friends with their grandchildren, and not being able to have that is agonizing at times. I mean, just agonizing at times. And especially during the holidays. And I think about future holidays where I won't have children or grandchildren. Oh God. Okay. I'm going to depress myself. No. Okay. I have to stop. Okay. But so what helps me is context. It's like, why? And I've always used a, I'm supposed to use this somehow approach. I whenever I have a flare or anything, anything weird that happens, it's like, all right, what can I learn from this that can help me and then help others? And yet there's this like bitter taste of regret about why did this happen in the first place? And this is what I know. I broke my tailbone in 7th grade. I had frequency urgency in 7th and 8th grade. I knew every bathroom in town. I got vulvodynia in high school and junior college. And what the doctors kept saying is, you have the most sensitive skin I've ever seen. And I couldn't wear jeans for a while. Then in college, I started throwing ovarian cysts, polycystic ovarian syndrome. And I'm not talking one or two, I'm talking dozens. We're talking emergency room, emergency surgery types of thing. And same thing happened to my sister. She also threw ovarian cysts. Then irritable bowel, violent irritable bowel. My first job, I remember on a break, I went down and I got a chocolate chip oatmeal cookie and a glass of milk. And within 20 minutes, I was in the fetal position in the employee bathroom. I worked for the feds back then in Marin County, California. I had the most violent bowel spasms of my life. And that was the start of irritable bowel syndrome. And then I got migraines for 6 months. They stopped, thank God. And then I was laying down and I could feel a fluttering in my chest. It's like, what the hell is this? And it was my muscles kind of quivering. And then, because I was laying down a lot back then, because I had bowel spasms every morning for 4 years until I figured out it was the freaking oatmeal that was doing it. I noticed that my feet would tingle whenever I needed to have a bowel movement. Okay, that kind of freaked me out for a while. And then when I was 32, I got through grad school. I became a presidential fellow, which was pretty damn good considering I felt like crap. And then when I was 32, the bladder pain started, and that was when life stopped, because you can't function if you can't sleep, and the pain was excruciating at first. And I remember I had a doctor say to me, "You will forever be a burden on your family. You will always live with severe pain. I get used to it. This is your life." And that's what woke me up. So I was like, wait. I have 3 college degrees, an award from the White House. I will prove you wrong, you son of a bitch. How dare you say that to me? And I started by reading. Because really, honestly, I was feeling sorry for myself and crying a lot. And I was very depressed and very anxious. And it's like, all right, wait a second, you son of a bitch. I will prove you wrong. So I started reading. And the more I read, the more I learned. And then, what happened, which is so interesting, it's like 2 or 3 years into it, and you have to make a decision that you're going to fight, right? You guys, you got to be freaking proactive here. You cannot sit in a room with the drapes shut, crying your eyes out. That will get you nowhere. We got to get up and move. We got to figure this stuff out. And for me, one of the things that was really important was when one of the first genetic studies came out, because one study from the University of Maryland came out that showed that sometimes this happened in families. I was like, oh, really? Well, my sister has this, my mother has this. And it was like, wait, you mean it wasn't my fault? Because I really thought during the worst of it, when my depression was absolutely at its worst, I really thought it was my fault. I thought that I had done something wrong. I believed truly that I was being punished. And that was a very, very heavy burden to carry. It was very heavy. And then we have the first genetic study. And it's like, oh, what? You mean it's not me? I really didn't do this? And it was like the weight lifted off of my shoulders. It's like, oh my God, it's not my fault? Oh, right? But now we understand why it happens in the first place, with the fact that, yes, we can inherit sensitivity. Linda said, I never felt that way. Oh, honey, I'm so glad that you didn't feel that way, because feeling that way is terrible. I was in a severe windup. So now, again, now that we got these new brain research with these brain scans, and we understand that after injury or trauma, the sympathetic nervous system, which normally protects you from, threats, the heart of the fight or flight response is controlled by the sympathetic nervous system. So if you saw a saber-toothed tiger, you go, whoa. The sympathetic nervous system, the amygdala turns on, your blood pressure is raised, your heart rate is raised, your muscles are tensed, your blood sugar levels change, because it is preparing you to fight for your life or to run. And then once a threat has passed, the parasympathetic nervous system takes over and it calms everything down. And our day-to-day life is supposed to be controlled by the parasympathetic nervous system. But some of us get stuck. They get stuck. And the sympathetic nervous system, and specifically the amygdala, is not turning off. And what does that do? What does that do? It leaves you with a massive amount of adrenaline floating through your bloodstream. It's like you're being poisoned by adrenaline. Adrenaline, again, is part of that fight or flight response. It drives anxiety. It drives depression. Pain that is accompanied by tears, anxiety, and depression is intensified by the brain, because the brain thinks you're fighting for your life. Pain that is accompanied by laughter is minimized by the brain. And so the very first thing we got to do is we got to turn the damn amygdala off and get the parasympathetic nervous system turned on. And that is what this magazine is dedicated to, going over the research and explaining how you do that. And it's freaking easy to do. Let's do it. Let's do another one. We did I Spy earlier. So remember, remember with the brain, it's not like you go from point A to point B. It's not like a straight line. The way the brain works is like a thunderstorm. Different parts light up. It's so cool. If you've ever flown over a thunderstorm at night, or even during the day, you see the different clouds lighting up. That's your brain. Because remember, your brain processes everything. Your brain adds context to everything. Your brain remembers every single memory. It remembers everything that's happened to you. Even if you don't remember it, your brain remembers it. So that when you are faced with something weird, your brain is trying to process it. Your brain's trying to figure it out. And it goes through your memories, it goes through all sorts of other stuff. And so, one of the ways that we turn the brain off is by distracting it. Distracting it. We can use we can engage the senses. We did I Spy earlier. That's one way to do it. So if we focus on smells and tastes and what you're hearing and seeing, that's one way of getting the brain to focus, to function normally rather than abnormally. Tapping is another way. Let's do let's do it. It's so interesting. So it's called the emotional freedom technique, but really what it is doing is it's engaging different parts of your brain to behave normally. So let's just try it. Let's just as a group, let's just do a session of tapping. It'll take like 3 minutes. So normally when you do tapping, you pick an issue that you want to work on. And so the issue is going to be, let's just say pelvic pain. And we have to pick something that we're going to say to ourselves. So we're going to say, yes, I have pelvic pain, but I love and appreciate myself. Yes, I have pelvic pain, but I love and appreciate myself. Now we're going to do tapping. Now the purpose with tapping, we're going to touch different parts of our body, is we're stimulating the brain in different ways. We're getting the brain to focus in different ways. So we're going to start first at the karate chop, the side of the arm. Okay. So I want you to do it with me. Okay. We're going to, let's see. We're going to tap 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Yes, I have pelvic pain, but I love and appreciate myself. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Yes, I have IC, but I love and appreciate myself. No reason why I shouldn't. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Yes, I have IC, but I love and appreciate myself. All right. Now we're going to go here, right at the start of your eyebrows. Okay. Right on the hair. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Yes, I have IC, but I love and appreciate myself. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Yes, I have IC, but I love and appreciate myself. There's no reason for me not to. IC doesn't change me. I deserve love. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Yes, I have IC, but I love and appreciate myself. I'm a good woman. Now we're going to go out here, not in your temple, but on the bone, that ridge of bone right on the outside of your eyes. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Yes, I have IC, but I love and appreciate myself anyway. Screw IC. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Yes, I have pelvic pain, but I love and appreciate myself. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Yes, I have IC, but I love and appreciate myself. Now we're going to go here, top of your cheekbone. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Yes, I have IC, but I love and appreciate myself. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Yes, I have pelvic pain, but I love and appreciate myself because I am worth love. I'm worthy of my family's love. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Yes, I have IC, but I love and appreciate myself. Right here. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Yes, I have IC, but I love and appreciate myself. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Yes, I have IC, and I love and appreciate myself. I am worthy. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Yes, I have IC, and I absolutely love and appreciate myself. It says nothing about me as a person. I'm a good person. Right here, right here. Like in the trough between your lips and above your cheekbone. 1, 2, 3, 4, 5, 7, 8, 9, 10. Yes, I have IC, and I love and appreciate myself. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Yes, I have IC, and I love and appreciate myself. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Yes, I have IC, but I love and appreciate myself. All right, now you got to go to your collarbone. So go to the tip of your collarbone. Let's see. It doesn't, look at that. It doesn't look matched. Okay. Go 1 inch below and 1 inch out. and tap there. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Yes, I have IC, and I damn well love and appreciate myself. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Yes, I have IC, and I'm a strong bitch ass woman, and I love and appreciate myself. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Do not mess with me. I am a good woman, and I'm going to defend myself. All right? You make it up. All right, now you got to go where your bra strap is for women. You're not in your armpit, you're here. Just do one side. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Yes, I have IC, and I love and appreciate myself. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Yes, I have IC. You bet. I got IC. I got no problems with you judging me because I don't judge myself. I love and appreciate myself. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Yes, I have IC, and I love and appreciate myself. And we're going to stop here, top of the head. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Yes, I have IC. Don't say anything about me as a person. I'm just hurt. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Got IC. Sister has IC. Mother has IC. Runs in the family. Who knew? 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Yes, I have IC. And I love and appreciate myself. I have done nothing wrong. None of this is my fault. I am a good woman. You are good. You are a good person. So you can tell it's cloudy outside. So the purpose of doing that, I know it sounds like psychobabble, but when you do this, you're forcing your brain to pay attention to that. You're forcing your brain to pay less attention to the anxiety and the fear and more attention to what's happening at this moment, aka mind body medicine. I think it's pretty damn cool. And we go through a lot more of it. There's a lot more techniques in here. And again, the research is from Harvard Medical School. Oh, and by the way, you guys, I was asked to write a chapter for a new book on pelvic pain that just came out also. And I can't believe I forgot to announce that in our magazine. Debbie says, love the tapping. I think it works. Positive thinking. Jill says, IC Network. Can I get onto the webpage? Can I call this number to get the magazine? Yes. 1-800-928-7496. Sure. Jill, pop me an email. IC Network. If you got my email, pop me an email. I'll get you that information. Loretta says, God bless you for sharing your deepest thoughts. God has used you in great ways. We all live with regrets, but you've chosen wisely. We love and appreciate you. You indeed are worthy. Thank you, hon. Woo, it's been a journey. What a life. Like I want to write a book about this. It's just so, but then you think about all the other people who have been born with other things. Dina says, is IC genetic? No, IC is not genetic. Nerve sensitization can be genetic. All about your subtype, Dina. Not everybody's the same. For some people, IC is a result of a muscle injury. For others, IC is a chemical injury to the bladder. It can be other conditions going on, like a fibroid tumor pushing on your bladder, or endometriosis, or a pelvic congestion syndrome. There's a lot of different things that can cause the symptoms that we associate with IC. The only genetics matter in IC subtype 5 central sensitization. So if you're not familiar with the subtypes, come on over to our website, icnetwork.org, and go to the video area. Is IC hereditary in any way? Again, you're not listening to what I'm saying. It depends upon what subtype you're talking about, Dina. Hunner's lesions are not hereditary. Hunner's lesions are viral infections. Bladder wall injuries are not hereditary. It's because of chemotherapy or it's because of chemical injury. Estrogen atrophy happens to every single woman. So yes, every woman's going to go through estrogen atrophy. Pelvic floor tension is not hereditary. Pelvic floor tension can come from a bony structure abnormality, one leg longer than the other, or some sort of traumatic pelvic injury, or a bad hip, or a bad SI joint, or a bad knee. So maybe if you've got rheumatoid arthritis in your family that leads to arthritis in a hip joint, which could then cause muscle tension, we could potentially say muscle tension could be hereditary in that respect. Pudendal neuralgia is not hereditary. It is a nerve that is being compressed. Central sensitization happens after injury. And for those of us who are of a Scandinavian, Northern European descent, some of us are born with more sensitive nerves. That's hereditary. I'm a redhead. Every woman in my family, we have sensitive skin. We have a sensitive stomach. We have a sensitive bowel. We're drug sensitive. We're food sensitive. There is a hereditary component to that. But bladder wall itself is not hereditary. It's usually injury or chronic infection or trauma of some type or estrogen atrophy. Does that make sense? Sherry says, are you still having fires in the area? No, hallelujah. Fire season officially ended a week ago, last Monday. Linda says, your bladder feels okay. Your urethra is on fire. So Linda, the urethra is the canary in the coal mine. Denise, we are live. We are live right now. She's asking, are you live now or is this a tape? This is live. It is Sunday, January 3rd at 4:32 Pacific time. So the urethra is kind of the canary in the coal mine when it comes to estrogen atrophy. And so remember that your bladder, your urethra, your vulva, and your vagina are all structures that rely on a nice thick coating of mucus to defend itself. There's a reason why our lips are moist. There's a reason why we have moisture in our vagina and our bladder and our urethra, because it's protective. Unfortunately, that mucus, that moisture is estrogen dependent. So when you're young and you have lots of estrogen, your urethra can protect itself. When you're older, you have much less estrogen. And guess what? The skin gets drier and more vulnerable. And it's the urethra that first starts screaming when your estrogen levels drop to a certain point. And so, Linda, I can't tell how old you are, but if you've had a surgical hysterectomy or you're 40 years or older, that is possibly and probably what is going on with you. The other reasons why the urethra will scream could be UTI. It could be an infection of the periurethral gland, or it could be a chemical reaction to laundry detergent, menstrual pads, things like that. But 9 times out of 10, we're talking estrogen atrophy. Pamela says she had brain surgery in 1999. How does this happen? How could this trigger IC and then the IC hit? Boy, isn't that a great question? I can't. The only connection between the brain and the bladder are nerves, right? And so, I can't imagine how that would happen, Pamela. I think that if the brain surgery left you with a lot of anxiety, and you're struggling with anxiety and catastrophizing, and you have a very high startle reflex, which shows that your sympathetic nervous system is maybe functioning a bit too much, I think that could explain why your bladder might be a little bit more sensitive. That'd be a great question to ask a neurosurgeon. Linda says, I'm on hormone replacement 1.5 milligrams a day. So if it's oral, you have to understand that oral hormone replacement does not get to the urethra to be significant. Normally they would have you rub a little bit of estrogen cream right into the entrance of your urethra. You're 58 now, 7 years, no symptoms. Yeah, but this is the perfect time for that to be happening. You're 58, you're drier. If your vulva's dry and your vagina's dry, then so's your urethra and so's your bladder. You had your right temporal lobe removed. You know, I'm just not, the brain is a fantastic organ, and I am just not an expert in any way, shape, or form. So I don't know, Pamela. You'd have to, dive in. Okay, so here, hold on a sec. I did put a couple of brain diagrams in here, just out of curiosity. So you have the right temporal lobe. The right temporal lobe it controls hearing, language, and memory. You asked your brain doctor. He said it's possible that yeah, but honey, there's no such thing as an icy bladder. You gotta be more specific here. Sorry, it's just the lights are going out. The lights are changing, so I'm just trying to adapt here. It's all about what structure is driving your symptom. You could have, for all we know, had pelvic congestion syndrome all that time. If you go through the day and you feel by the end of the day that you're carrying a bowling ball in your pelvis, then you have varicose veins in your pelvis called pelvic congestion syndrome that would cause all the symptoms that we associate with IC. That is very easily treated. If you have a fibroid tumor pushing on your bladder, if you've got endometriosis that's attached to your bladder, if you've got a mechanical issue, if you've got one leg longer than the other, if you're not walking normally, that would affect your muscles, that could affect your bladder, et cetera, et cetera. But it's really hard. You guys, you just have to remember that IC is a grab bag diagnosis. It's what they tell you have if they can't figure out what's causing it. And so being with a IC and pelvic pain specialist is a must, because they've got to understand all of the structures that can, here's the deal. And let me get my thing here. Well, I want you to look at this for a moment. I mean, this is really important here. So look, this is a pelvis. Whoops. So here's a pelvis, right? The way the human body is built is the bigger the bones, the more weight it's meant to carry. And so you can clearly see that the pelvis carries the weight of the torso, right? But the pelvis also absorbs the stresses from your legs and your feet. So it's taking pressure from the top down by holding your structures up, but it's also absorbing stuff that's happening when you're walking and stumbling. Like, for example, if you ever rear-ended somebody else and you had your leg extended, your leg extended on the brake pedal, and you hit somebody, the force of that comes right up your muscles and up your bones and up your fascia, right into your pelvis. And quite a few people end up with pelvic floor issues because of accidents like that. So the pelvis is the center of the human body, but there's a hell of a lot happening in the pelvis. So the first thing that's happening is we got muscles down there. These are your pelvic floor muscles. These are the muscles that help you open your legs and walk, right? They help you open your hips, drop your knees to the side. So there's important structural things that are happening in the pelvis. We also know that inside the pelvis, we have blood vessels that are coming through, major blood vessels coming through and splitting and going down both legs. We know that we're getting a lot of nerves. Every one of these holes in the sacrum, nerves come through. And those nerves come through and they go through muscles. and then they innervate structures in the pelvis, but they also go down the legs, right? AKA sciatica. Then you got to throw in organs. So let's put in some organs here. So hello, uterus. Oh, wait, hold on. I got to put on the outer muscles. The other thing that makes the pelvic floor muscles even more unusual in the human body is that they also control major bodily functions. So here are your levator muscles. And you'll notice for a woman, there's 3 holes. We got a rectum, we got a vagina, we got a urethra. Now imagine what would happen if these muscles are tight. It gets squeezed, which is why it's hard to pee when you have tight pelvic floor muscles. You know, if you're standing there 5, 10, 15, 20, 30 seconds before you can relax enough to pee, you got tight levator muscles right up here. If it's painful to have a penis put in your vagina, it's because you got tight muscles right here and maybe deeper muscles. If it's hard, if you're struggling with constipation and you have pain after having a bowel movement, odds are you got an issue with these muscles right here, right? So these muscles are very complex muscles. But then, of course, we've got freaking structures. So let's put hello vagina and ovaries in here, right? All right. So look, that's taking up space. Hello bladder. Let's put the bladder in here. And look, so now you can see, you know, for those of you, when we ask where the pain is located, right? And so here's your pubic bone. And so if you're putting your hands right above your pubic bone, then we know you're touching your bladder, right? So there we go. Hello, Mr. Bladder. Hello, bowel. Now we got to stick the bowel in here. And I'm telling you, of all these organs, the bowel is the hardest to get in here. Let's see. It is really hard to get in there. All right. So look, now we got the bowel in there. And proximity matters here. Western medicine fails the pelvic pain patient because doctors like to stay in their box. They stay in their specialty. You have pelvic pain, you go to a urologist, they're going to look at your bladder and your urinary tract. Other patients are going to go to maybe a gastroenterologist. They're going to work on the bowel. If you go to your OBGYN for women, they're going to look at all this stuff. What they don't study and they don't consider is relationships. That these do not function in isolation. This is a very small confined area, and these structures influence each other. So you notice that if you're constipated and your bladder is more irritated, that's because you've got stool accumulating right there, pushing on your bladder. If you have endometriosis that's coming out of your uterus, up the fallopian tubes, you can see how easy it's going to be for that endometriosis to come down here and wrap around your bowel and wrap around your bladder, as well as go upwards. And so really, unlike 20 years ago, when everybody considered IC a bladder disease, we don't anymore. And we haven't since 2008. Because it was in 2008 that our first study showed that muscle therapy helped. And when that happened, we all went, uh-oh. If pelvic floor physical therapy outperformed Elmeron and bladder treatments and reduced your symptoms, maybe for some of you, it's a muscle problem, right? So look, so now let's go back. Let's take these out. And now we're confronted with the muscles. And the challenge with this muscle group is y'all can't see it from the outside, and you really can't touch it from the outside. So if you got a problem with one of these muscles, it's hard to find. It's hard to diagnose. And that's when you go to a pelvic floor physical therapist. You know, if your urologist or your gynecologist says, yeah, your muscles are tight, you're going to go to pelvic physical therapy. And yeah, they're going to do external stuff. But the best way to reach these muscles is internally with a finger up, you know where. And what they're going to do is they're going to follow muscle groups. You see what I'm doing there? That's what they do. A tight muscle contracts. We have to try to get the muscle to flatten. And so when they do internal pelvic floor therapy, you can see what they're doing. They're just following the length of the muscle. And sometimes they'll go across the muscle. That's another way to kind of get that muscle to release. And if you have a trigger point, they will maybe push on the trigger point for 5 seconds or 10 seconds and then release, push on the trigger point, release. And what's interesting when you go to pelvic floor physical therapy is they're going to be, you can feel them rubbing up the inside of your hip bone. I mean, it's really interesting, and it doesn't hurt at all. I mean, bones don't hurt. The muscle, and you know, the mistake people make is that they get scared because during that first assessment, they're just touching muscle. All they're trying to do is figure out where the pain's coming from. And so they're gonna find your hot spot, and you're gonna go, oh, that's it. And your next question is going to be, what are you touching? And they're going to say, oh yeah, look, that's your piriformis muscle or your levator muscle or your obturator, whichever. Then you have to go back and they're going to work on that. Now, some of you are very reluctant to have internal work, especially if you have a history of abuse. I understand that. Everybody understands that. And, you know, you can see through my finger. This is the best way to do it. This is really it's amazing how effective this is if we can just get these muscles functioning correctly and in the right position. But if you have a history of abuse and you can't tolerate anybody going there, number one, tell your physical therapist that. Don't be ashamed. It's not your fault. And they will start externally. They can work with your glutes and your lower back and your legs. And hopefully over time, you will build a trust relationship with them. They will always tell you what they're working on, and you will always ask. And man, information is power here. It's really cool to be able to walk in and know the freaking structures they're talking about. Breaking Through Chronic Pelvic Pain is a masterclass in pelvic anatomy. And if you're somebody with a history of abuse and you're afraid to have people touch you, this will ease your worries because it will help you understand what they're doing. And ideally, hopefully, they will get to a point where eventually they can do that. And then others of you, you know, man, your muscles have been locked down for decades. Decades. You might have been beaten for wetting the bed and just gone into muscle tension from childhood. That's possible. This is not going to be fixed in 6 pelvic therapy sessions. This is about you doing the work. Most important part of pelvic floor physical therapy is what you do when you get home. And hopefully you will have a glass wand. We sell them. This one is called Easy Magic. Because you have got to learn the signals when your pelvis starts to get tight and get in there and do the work. And boy, I'm doing that right now. Ever since my hysterectomy, 3 years ago, I never really understood the importance of it. Now, as soon as I feel my muscles getting wacky on one side, out comes the wand. And you can see that it helps you without your finger. Let's see, it's really hard to do it like this. So you're mimicking what the physical therapist can do. And so these glass wands are wonderful. Glass is preferred over plastic. There are some vaginal dilators that are plastic. They can leave plastic in your body. Glass is the way to go. It doesn't break. I've dropped this many, many times. So you can get this in the IC Network shop and ask your physical therapist how to use it. Like my physical therapist kept saying, it's a J shape. Move in a J shape. For a year, I was like, I don't get the J shape. I just stick my finger in. I stick my wand in there and push around. He's like, no, it's a J shape. And it was the book along with this really helped me see, yeah, it is a J shape. See, look, it's totally a J shape on both sides. And some physical therapists will also teach your spouse how to do this. But it's amazing how successful this is. And again, we knew that in 2008 with the National Institutes of Health IC study. Denise on YouTube. Let's see. You can't tolerate honey or anything sweet. What's up? I would suspect you have a candida overgrowth. I bet you've got a candida infection in your urinary tract. If you flare with sugar, with honey, then we're talking candida most likely. Joanna says she got approved for disability. Yeah, baby. Congratulations. Yeah. How about a tilted uterus? Absolutely. If that uterus is tilting it towards the bladder, absolutely. Denise says, why wouldn't 10 milligrams of Percocet work? Well, you know, hon, the more you take pain medication, the more your body gets used to it and it gets better at breaking it up. And that's called tolerance. And so you could have some tolerance going on. You know, every time you take anything new, the number one job of your liver is to figure out how to get rid of it, break it up. And so the more you take it, the better your body gets at breaking it up. And that's very true with opiate medications, is that you have to take, it gets so good at breaking it up and that you have to take more and more and more. And that's where we get into trouble, because the more opiates you take, then you could have problems with breathing and other things like that. That's why we want to try to get to the fundamental problem. So, I mean, you've got a tilted uterus. Is there anything they can do about that? And then you get constipated. Yeah, because that's a side effect of opiate medication. I take, because again, I've got 2 bulging discs because I ruptured 2 discs this fall. I take one last night at 4 a.m, because that's when it hurts the most, at 4 a.m, 1/4 of a 5 milligram Norco. I cut mine in quarters. And that turns it off eventually. After about 20 minutes, it turns off. But even with that, so little, I definitely can feel that it's affecting my bowels to a certain degree. Fiber and water, acacia fiber and water. Yeah. Dina says, you're wondering if it's birth control for my daughter as well. We have our first case study, which showed an 18-year-old woman who started birth control 2 weeks later, ended up with symptoms of IC. They worsened over a period of a year. She went to 5 specialists. She got a diagnosis of IC. She got a diagnosis of candida. She got a diagnosis of whatever. They gave her diagnosis after diagnosis. None of the therapies worked. And finally, she went to a doctor who said, hey, you didn't start birth control, did you? She said, yeah. And she said they stopped the birth control. And it took several weeks, but her symptoms went away. So birth control will reduce estrogen, which will make the bladder more vulnerable. So yes, absolutely, birth control can be an issue. And Dina, if you send me your email address, icnetwork@mac.com, or your snail mail address, I will send you our latest magazine. Pamela says, I have a bowling ball for years, no help on it. So we did an article on that. Pamela, if you're a member, you can go into the back issues. I mean, I think I did it in the last year or 18 months. You have to see a specific type of radiologist. I think they call them an interventional radiologist, to look for the veins. Yeah, but that bowling ball sensation, that is a classic pelvic congestion syndrome symptom. Linda says, I'm trying low-dose naltrexone. It does help with mood at least. I think mine might be pelvic, as it's worsened by car rides. You know, mine was killed by car rides, like literally from day one. I can remember as a kid having issues with car rides and having to stop and use the restroom all the time. Linda says, I had the worst IBS of my life this summer, and then the IC flare. Well, I mean, guys, you got to be honest here. Listen, we are all living with a hell of a lot of stress and anxiety right now. Like, holy crap. And the stress is the stress is intensified now because now we have this super resistant, I mean, not super resistant, the super infectious COVID going around. It's supposedly not more severe, but it takes less virus to infect somebody. So for God's sake, people, wear a frickin' mask. They are finding the virus in urine, in bladders, and our study with IC and people with COVID shows that it is dramatically intensifying and worsening flares. Worsening flares in quite a few people, and it's bringing some patients out of remission. So do it for your IC. For God's sake, wear a mask. Man, I am next 6 months until I can get the vaccine. I got to go get a prescription for my mom at our supermarket. I go early tomorrow morning. I'll tell you what I do. You guys, I have a lot of medical training, so I understand the dangers of this. I have eyeglasses. I wear 2 masks, one with a filter. And if I don't want to wash my hair, I wear a hat and I wear a hoodie. I want all my hair covered so I don't have to come home and wash my hair because we are having a really big COVID outbreak where I am. And then I leave my shoes in the garage for a couple of days and usually take off. I try to wear a lot of layers. And so my outer layer goes right into the tub. Right into the washer. That's what I do. Because I'm trying to protect a 98-year-old and a 91-year-old. And it's going to be, the next 6 months are going to be tough. But we're going to do it because we're tough cookies. We are tough cookies. I want to say we're a kick-ass bitch. I'm willing to say that. After the year we've gone through, feel free to swear. It's okay. All right, guys. Well, listen, we've been going on for 4 hours and 15 minutes, which means I'm going to be stiff as hell when I get up. I am going to give you your homework. You have homework. For 15 minutes a day, I need you to do something for your noggin up here. Read something. Send me an email, send you our newsletter. Read an article a day. For God's sake, got to get your knowledge level up. I want you to be able to be like me, walking into a doctor's office, prepared to kick ass if anybody says the IC isn't real. I will be able to prove them wrong. I want you to be able to do exactly the same thing. It begins with your knowledge level. For 15 minutes a day, I need you to do something for your body, either your bladder or your pelvic floor or your brain. You do EFT, do I Spy, do your pelvic floor, follow the diet, do something that will help your body get to a better place. For 15 minutes a day, I need you to do something for your spirit. This is hard. This is hard. And you need comfort, and you deserve comfort, and you deserve rewards. Every time you go to the doctor, reward yourself. Have a cookie, for God's sake. It's okay. Even though my resolution this year is no cookies, cakes, or pastries. We'll see. That could change depending upon my stress level. But I've made it 3 days so far. I've been eating a lot of cookies and a lot of pastries the last year. But anyway, reward yourself. And if you get comfort by watching a church service on Zoom, do it. Don't go to church. Please don't right now. COVID is too active, or sit in your car and do the video, whatever. But nurture your spirit. Go take a hike, pet your cat, sit in front of a fire with a cat in your lap, read a book, do something that will give you comfort. And for 15 minutes a day, I need you to do something that will bring laughter into your life, because when you laugh, your brain minimizes your pain. So I need you to laugh a little bit more. So please watch funny videos or TikTok or call a friend and just laugh. All right. What's a urine test for Candida? It's a next generation urine test. Go to bladderhealth.org and you can see the light that's getting dark outside, and now everything's bright in here. So I'm going to have to go. Elizabeth Haynes, big giant hug, hun. You are not alone. Y'all are not alone. We're here. We're here. We're going to do this together. Make sure you subscribe to our YouTube channel. Come on over to our YouTube channel. Put a like on there so I can do more on there. The more likes we have, the better I can do, or subscribe to that. Like our Facebook page. Again, come on over to our website, icnetwork.org. And, if you found this helpful, you can make a donation. You don't have to. It's free. It always has been free. Or you can become a member and get our magazine, because I think it's a pretty good magazine. We've been doing that for 16 years now. All righty. Did I miss anything? I'm just making sure I haven't missed anything. Yep, Walgreens delivers prescriptions. All right, Cara. All right, you guys. Big hug. Happy New Year. It's a new year. Praise God. Hallelujah. 2020 is over. Whew. All right. See you later. All right. Facebook is done. Thank you, Denise. Yeah. Well, it's Southern California is really messed up. Northern California is much better where I am, but, between the fires. Thank you, Donna. Big hug. Happy New Year.